Good afternoon, friends. And the recording is on this side. Yeah. Good afternoon, friends, everyone, and all doctors and all the doctors online as well. I myself am Dr. Abhilash Tiwari, the organizing secretary for this conference. I hereby welcome all the learned audience. And to begin with, request Dr. Sabyasachi Ray, who is the chairman of the Indian chapter of the Royal College of Physicians of the Ireland, as well as a regional advisor, to come on the dais and to give us the welcome address. I request Dr. Ray sir. Yeah, I request Dr. Ray sir to just speak a few words about our college. Yeah, and on the welcome address, I request Dr. Ray sir to give a short talk on the welcome address.
Good afternoon, everyone. I'm sorry for my voice. I'll try to be clearer, but I'd like to begin with saying that on behalf of the fellow and members of the Indian chapter, Royal College of Physicians of Ireland, I extend my cordial welcome to you all. I'm speaking about the college, which is one of the oldest medical institution in the world, and just completed 367th year. And we have been working as an emissary of the college since 2005, when we were officially inaugurated Indian chapter. And since then, we have been organizing CME, other medical activities by ourselves or with other institutions and organizations in this country and even neighboring countries to continue academic work. And also we are conducting the ICRCPI examination along with the college. Unfortunately, due to COVID-19 pandemics, all these activities were put on hold for a while. Since last year, we've started working again, but virtually with series of webinars until recently. And now that the restriction has been taken off, we have been thinking of the CME, and today's event is the first of this kind. And we are very happy to see our organizing secretary, Dr. Abhilash Tiwari, has done a tireless job to conduct this program. And without further delay, I'll hand over the mic to Abhilash again to continue the proceedings.
Thank you, sir, for this kind welcome address. Our next speaker will be Professor Dr. D.G. Jain. Just I want to brief about sir. Dr. D.G. Jain, sir, is a consultant in internal and pulmonary medicine. He is an honorary affiliate professor of medicine and former member, Academic Senate, Manipal University. He is the immediate past president chairman of the API Delhi State Chapter. He is a well-trained, eminent, and outstanding clinician with a special interest in training in pulmonary and critical care medicine from India as well as abroad. Dr. Jain sir is an examiner for the MRCP final examination since last 12 years. He is also a trustee of Tirth Ram Shah Hospital located at New Delhi. Dr. Jain sir has edited a number of books, including the emergency medicine, clinical medicine, and many medicine updates. He has been editor of the journal Indian Academy of Clinical Medicine, and he is a deputy editor of the Journal of the Science of Healing Outcomes. He has contributed chapters in the pulmonary medicine to 8th, 9th, and 10th edition, which is one of the popular textbooks which is known in India by all the physicians by the name of API, Textbook of Medicine. I hereby request Dr. Jain sir to please come on the dais and to talk about his expertise as well as talk about the physician, what the physician should know about the immunization, as well as to give some introduction about the MRCP examination. Dr. D.G. Jain sir.
Good afternoon, friends, and season's greetings to all the distinguished members of the medical fraternity gathered here today under the auspices of the Indian chapter of the RCPI. I'm grateful to the Regional Advisor and Chairman of the Indian chapter of the RCPI, Dr. Sabyasachi Ray, Vice Chairman, Dr. M.K. Mukhopadhyay, and Dr. Sujoy Mazumdar, and our dynamic organizing secretary, Dr. Avilash Tiwari, for inviting me to this update to present an overview of the MRCPI examination and what the MRCPI qualification means internationally from the career point of view. For all of you medical students, interns, resident doctors, postgraduates and postgraduate trainees and physicians who wish to carve out a bright future in clinical medicine, the ultimate aim or goal ought to be the MRCPI, that is the membership of the Royal College of Physicians of Ireland, which is recognized around the world as an international benchmark of excellence in medicine, opening up new opportunities for career advancement. By successfully completing the MRCPI examination, you are joining a global network of respected physicians whose roots date back to 1654. It also sets you on the pathway to fellowship of the Royal College, which is a career milestone in itself and an international benchmark of professional excellence. Our fellows are experienced hospital consultants who have made substantial contributions to this specialty. Globally, there are over 11,000 fellows, members, licentiates, and trainees in 84 countries. As I said, the Royal College of Physicians of Ireland is the largest postgraduate medical institution there. Its aim is to develop and maintain high professional standards in specialist medical practice in order to achieve optimum patient care and to promote health nationally and internationally. The Royal College of Physicians was founded in 1654. It has an international faculty. It has the Irish Forum and Academy of Medical Royal Colleges. It is not for profit and self-funding, governed mainly by fellows of the college and administrative officers. Primary concerns of the RCPI, as I said, was maintaining high standards in medicine through postgraduate education, examinations, that is memberships and diplomas, cooperation with the government on healthcare matters, policy development, advocacy and public engagement, professional competence assurance, and supporting professional development. College activities throughout the year are training and education opportunities, CMEs, PG examinations in Ireland and overseas, including the MRCP exam, public meeting series in association with governments and NGOs. Now, this is the structure of the Royal College of Ireland. I'll not go into the detail. These are the training bodies, that is the Faculty of Pediatrics, Faculty of Pathology, Faculty of Public Health, Faculty of Occupational Medicine, Institute of Obstetrics and Gynecologists, and other 16 subspecialties. RCPI has international activities in Saudi Arabia, in Muscat, Oman, in India, Kolkata, then in Malaysia, that is Kuala Lumpur and Penang, then UAE, that is Dubai, in UAE, Al Ain, Perth, Australia, and also in New Delhi. The Indian chapter of the RCPI was the initiative of Padma Vibhushan, Professor B.M. Hegde, the then Vice Chancellor of the Manipal University. It was formed in November 2004 at Kolkata, as Dr. Ray has just told you, and was officially inaugurated on 4th September 2005 by Dr. Stanley Roberts, the past president of the RCPI. Dr. Sabyasachi Ray is a regional advisor of the RCPI and is its dynamic chairman since inception. Coming to the MRCPI examination, as I said, it's an international benchmark PG exam recognized by most countries of the world. Upon qualifying this exam, you become eligible to apply for a consultant's post anywhere in the world. Who should think of the MRCPI? MBBS graduates who wish to pursue a career in clinical medicine and become consultants. And unlike the MD, DNB, and DM admission process, no entrance exam like NEET is required for the MRCPI. All those taking any PG exam in medicines, that is MD, DM, DNB, should and can avail this opportunity to add an internationally recognized qualification with the same preparation. MRCPI examinations in India commenced for the first time in Kolkata in September 2005, held 2-3 times every year. MRCPI Part 2 written exam commenced in November 2006, again in Calcutta. Then MRCPI Part 2 clinical exam commenced in December 2007 in Kolkata. In 2015, it was held in Mumbai. MRCPI Part 1 exam was held for the first time in North India in 2012 at the Tirthram Shah Hospital, Delhi's oldest and premier hospital, which was inaugurated by our first president, Dr. Rajendra Prasad. Now, about the MRCPI, I'll go through a couple of things. Number one is the benefits of passing the MRCPI examination, the examination structure, the preparation required, the question structure, and the knowledge examined, and finally, the frequently asked questions. Now, in section one, I'll go through benefits of passing the MRCPI examination, an entry requirement for trainees who wish to become eligible to apply for higher specialist training, a requirement for doctors who wish to become members, the use of the post-nominal MRCPI, international recognition, also acts as an excellent yardstick with which to measure your own knowledge and competence in medicine. MRCPI qualification rules are like this. There is a part 1 written exam, then there is a part 2 written exam, and you have a time frame of 7 years in which to clear the part 2 written exam after qualifying the part 1. You have to apply for it. And again, after qualifying the part 2 written exam, you have 2 years time to clear the part 2 clinical, for which again you have to apply. Now I come to the examination structure. Objectives of the MRCPI exam are to assess a candidate's knowledge and understanding of basic sciences relevant to medical practice and the common or important disorders to a level appropriate for entry to specialist training. Now in MRCPI part 1, we have 100 single best answer style questions of 3 hours duration. Average, you get 1.8 minutes per question. It is spread across specialties. It includes the science underlying medical practice and medical disease, basic skills required in general medicine, and common or important diseases in hospital or community practice. Now, the part 2 written exam is a bit different. It is open to candidates who have passed MRCP part 1 written within 7 years. Written section consists of 2 best of many format question papers of 2.5 hours each. Questions may include photographs of clinical findings, including retinal photographs, imaging and graphical data, and pathological material relating to the question. Now, 2 papers of 75 single best answer questions are there. Average, you get 2 minutes per question with a 1 hour break in between. There are no basic science questions in this paper. The stems of questions are generally more descriptive and longer than part 1, and it requires interpretation of investigation and quick data analysis. Now, this is a small comparison between part 1 and part 2. I won't go through this. Objectives of the MRCPI clinical exam are eligibility, number 1. Candidates who have successfully passed part 1 and part 2 general medicine written exam. The exam consists of 1 long case. Candidate spends 45 minutes with the patient and therefore is examined by 1 examiner for about 30 minutes maximum. Short cases are 5 to 6. Specific system is examined in each patient, 5 to 7 minutes for examining each patient. A different examiner examines the candidate for each short case for a total duration of 30 minutes for the 5-6 cases. Now, in the long case, the points for examination are systemic presentation of history, correct establishment of facts, communication skill, clinical acumen, investigation, and management, about which you should know. Points for examination for the system examined in the short cases are correct establishment of facts, technique, errors, omissions, and clinical acumen. Now, there is a 3-point system for scoring. It is a mixture of individual skills and global assessments, and long case weighing 1/3 or 1/4 of the final mark. Now, I come to the preparation, which is very crucial. You should gain clinical experience in suitable hospital posts, become familiar with the curricula, refer to the RCPI website, and read examination relevant information. You should study up-to-date textbooks and current medical journals, take study leave where possible, attend tutorials where possible, and practice single best answer questions, books or online. Each question has only 1 best answer. This is the answer format. Each question focuses on an important concept, typically a common or potentially acute clinical problem, and assesses application of knowledge rather than the recall of facts. This is very important. Questions are complete, concise, clear, and unambiguous. Now I come to the question structure. Number 1, the main thing is the STEM, that is clinical case presentation. Number 2, there's the lead in the question. For example, what's the most likely cause? Number 3 is the series of options with 1 or most correct answers and 4 distractors. The STEM is written in such a way that it could be answered without the presentation of options, usually long, where options are short. Generally will include a case history, examination finding, lab or test result, and any other relevant information. Although some questions may pose a general scenario followed by a lead-in options, the lead-in presents the question as a single dilemma, and the types of questions are basic science questions. These are there only in the part 1 written exam. What is the underlying cause? What is the underlying diagnosis? What change to medication would you advise? What is the correct management or the next step in management? What is the cause of the diagnosis? What would be the most useful measurement? What is the likely cause of results? What is the likely explanation for results? What is the likely organism? What is the most likely toxin? What is the physical sign most likely to be present? And what would be the treatment plan? What investigations to carry out? Which is the best treatment? Why did the medication fail? Which test to administer? Now, series of options could include any of the following sets: sites of lesions, list of nerves, muscles, enzymes, hormones, all that, and autopsy results, results of microscopic examination of fluids, muscle or joint tissue, DNA analysis results, serum levels, underlying mechanism of the disease, medications, viruses, metabolic effects, vitamins, dietary elements, amino acids, endocrine structure. We need to know a little bit about all this, This is the MRCP Part 1 answer sheet. It is read by an optical scanner. Now, answer sheet guidelines are: you are advised to mark the sheet throughout the examination rather than leaving it to the end, as you may run out of time. If you write answers into the question book, you must ensure you leave sufficient time, that is 30 minutes, to transfer them to the answer sheet. No marks are received when two options are accidentally marked, so pay attention to the line of marking. And as there is no negative marking, you should attempt all questions. Now, what is the knowledge which is examined in the MRCP? In the MRCP Part 1, we examine all the basic, the specialties in sciences, that is anatomy, biochemistry, and all that. And then cardiovascular, dermatology, endocrinology, in fact, all the systems basically, including therapeutics and pharmacology, rheumatology, respiratory medicine. Now I come to the Part 2 written, the specialities and sciences that are, asked. Now here there is a breakup, of the percentage of questions asked. Cardiology 10%, dermatology 5%, endocrinology and metabolic medicine 10%, gastroenterology 10%, immunology, hematology 10%, like that, So this is a full breakup. Therapeutics and toxicology 5%. Knowledge and skills integrated in the question are: management of emergencies in medicine, application of knowledge of disease, including mechanism, then interpretation of clinical information, then interpretation of data, interpretation of images, planning investigations, planning drug therapy, planning non-drug therapy. Basically, if you're working in a hospital, I think one becomes familiar with all these things. Basic sciences examined in Part 1 only. It includes all these basic sciences. This is a little tough, to do Part 1 now. And the basic science questions, I will not go into the details of this. This is a sample. Now, considerations. The identification of the most likely cause of diagnosis is the most frequent lead-in question. However, the STEM can challenge you to approach the question from a variety of dimensions. For example, I'll go into a little question, this is an example. A 55-year-old woman presented with acute and slightly painful edema in her left lower leg. On examination, her leg seemed tender, showing pitting edema, and was slightly discolored. What is the most likely diagnosis? Deep vein thrombosis, early heart failure, idiopathic edema, pulmonary hypertension, venous insufficiency. So we have a best answer here, and this is the best answer, that is deep vein thrombosis. Now, this is another diagnosis question. There are many, actually, I will not go through all this. Now, this is an interesting one. Again, a diagnosis question. A 77-year-old woman presented with an insidious onset of fatigue and a burning sensation of the tongue on swallowing food. 6 years earlier, she had undergone a total gastrectomy for early gastric cancer, which was curative. On physical examination, she was pale, had a depapillated, smooth, shiny red tongue with some central fissuring, and findings that were consistent with a beefy red tongue. So what is the most likely diagnosis? This is chronic pancreatitis or celiac disease or vitamin C over-the-counter usage or poor diet or pernicious anemia. So now we have to find the best answer to this. So now we come to the best answer, which is answer E, that is pernicious anemia. Now, managing emergencies questions. It describes a case brought into the emergency department or a case with emergency symptoms presenting. Might be asked for a variety of aspects in the management. The next steps of management, most likely cause, possible diagnosis, initial therapy, investigation, or which medications to stop or start. Now, this is an emergency question. I will not go there up plenty. Now we come to knowledge of disease, including the mechanism. Knowledge of molecular and cellular basis of disease is important. The disease, including symptoms, presentation, indicators, causes, examination, investigations, etc., etc. Now we come to interpretation of data and clinical information. This might include laboratory findings, examination findings, history, and test findings, for example, X-ray or spirometry, then clinical test results. Now here, this is an information question, but I think I will not go into it. It's time consuming. Now we come to interpreting images. Provided along with a case presentation, could include X-rays, MRI and CT scans, gram stains, ECG sketches, diagrams, graphs, etc., etc. Now, this is an interesting one. A 21-year-old woman is admitted with this rash covering most of her body. She had fever, 100.9. Which of the following is the most appropriate treatment? Now, this is a question with an image. Acyclovir, flucloxacin, ganciclovir, paracetamol, and varicella zoster immunoglobulin. Now, this is the best answer is acyclovir. Now, planning investigations. Need to consider appropriateness in terms of match to the suspected diagnosis, potential elimination of differential diagnosis, most reliable data, more information than other tests, sensitivity of a test, even false negative rate, risk group patient. That was a sample question. Now, planning drug therapy. Considerations are drug administration, correct or safe dosage, drug responses, overdosage, contraindications, drug interactions, drug interaction, drug and nutrients, drugs and pregnancy, side effects, allergies. Now, consideration for selection of drug therapy. The planning drug therapy, this is another question, interesting one, but I'll not go into the detail. Toxin-related questions. For this, you should know how poisons work, global classification of toxicity, types of toxicity, toxicology, microbiology, you should know a bit, and clinical features of toxin exposure. This is very important. Then diagnosis and treatment, then degree of exposure and acute toxicity, assessment and treatment of acute or chronic poisoning, adverse drug reactions and overdosage. Reading and interpreting toxicology is very important. Factors influencing toxicology such as age and length of exposure. This is a toxin-related questions. This is just a sample, I won't go into it. Planning non-drug therapy. The number of possible non-drug options available and selecting the most appropriate one for the presented case. This is also a sample question, so I will not go into laboratory findings prediction, the connection between hypothesized disease and its associated lab findings. So again, here's a sample. Now, frequently asked questions. Is there a course recommended to help with preparation for the examination? There is no specific course provided by the RCPI as such. However, we recommend you to attend hospital-led tutorials where available. And for example, we have this med prep course about which Avilash will tell you. And is there a suggested reading list? I will give this list at the end of this talk. No specific textbook is available. Prepare by gaining clinical experience, following curricula, studying up-to-date clinical matter and textbook. How long until I find out my results? 4 weeks after the exam. How many times can I attempt the MRCPI examination? There are no restrictions in the number of times you attempt the examination. However, the time frames of 7 years from passing MRCP Part 1 to passing MRCPI Part 2 written and 2 years from passing MRCPI Part 2 written to passing MRCPI Part 2 clinical apply. How much training is required before attempting the MRCPI Part 2 written examination? You may attempt the exam once you complete a minimum of 12 months training from the date you complete your primary medical degree, that is MBBS, which is usually at the end of your internship year. What is the pass rate and how is it calculated? It is a statistical method, I won't go into the detail. Therefore, pass rate is different for each year, How can I purchase? Can I purchase pass papers? No. It is the policy of the college not to offer pass papers for sale in order to protect the integrity of the examination. How are my results achieved? Examination mark sheets are marked by a computer. Standard necessary to achieve a pass is established by various methods, including criterion referencing. If I fail an examination, can it be appealed? If you fail, you will receive a detailed fail letter, after which point you can appeal. A recheck request must be made in writing to the Dean of Examinations. If I have Part 1 of the MRCP UK, can I be exempt from the MRCPI Part 1 examination? No. A full MRCP UK is required to proceed directly to the MRCPI Part 2 written examination. If I apply and pay for the examination, but I'm unable to sit it, will I have my fee refunded? If you withdraw before the closing date, you are entitled to 90% of the refund. However, after the closing date, the fee is non-refundable. This was pre-lockdown. This is pre-lockdown information. Part 1 used to be held in September in Calcutta, Part 2 in March, and dates and costs change from year to year. So you have to check the website. Basically, all these details are on the website. And this is a guide for tutorial development for the MRCP. I'll go through this very quickly. You choose a topic, present the topic, present a case, considerations for the end of a tutorial, then structure of a tutorial. I will go through an example of a respiratory tutorial. Select a specialty topic, a disease, condition, etc. from the curricula which is relevant to the exam. Become familiar with the examination blueprint for guideline available on the website. Present the topic to include brief overview, prevalence, common and less common causes, diagnosis and differential diagnosis, associated factors, what makes it unique, oblique, difficult, or usual or unusual, other potential complications, and presentation of a relevant case, ideally a real patient. Case presentation should include relevant case history, other risk factors and why they are a risk, what to look for on examination, tools that could be used to assess severity, category, admission, what investigations to perform and why, how to treat and manage the patient and why, include any other relevant information. At the end, consider if there is other relevant information that would be useful to include, but not necessarily directly matched with the case presentation, and leaving time for questions and answers. So structure of a tutorial will be like this. Start with the question without presenting the topic of the tutorial. Allow participants to struggle with the question by having a separate slide with the 5 options. Discuss the options, their merits, and why they may or may not be the best single answer in the case presented. Provide the correct answer and continue with the tutorial presentation. Allow time for question and answers, discussion, and feedback. The more you discuss, the more experienced you will become in facing the exam. Now, here's an example of a respiratory tutorial. I'll just breeze through it. It can be used as a template. Now, here below is an X-ray image of a 49-year-old woman who presented with a 5-day history of cough productive of green sputum in association with fever, dyspnea, left-sided pleuritic chest pain. She was admitted to hospital, treated for similar symptoms 3 weeks prior to this admission. Past medical history included alcohol-dependent syndrome. Below here is a chest radiograph taken on the current admission. Most likely diagnosis, here's C, slowly resolving pneumonia. I will not go into all these details now. Now, in the case discussion, for example, case discussions will be like this. Why is diabetes a risk factor in these patients? And what would you look for on examination and all that, Pneumonia severity scores. This is all respiratory case, Comorbidities, physical exam findings, then lab and radiographic findings. Then these are tools to decide on admission. How will decide whether the case needs admission or not. What treatment do you prescribe? Something about interstitial pneumonia, like that, one can prepare. Now, here's the additional RCPI information. This is about the basic specialist training. I don't think we need to go into all that. There are 53 examinations, approximately 2,800 candidates are examined, and 280 plus candidates are conferred with membership. Now, MRCPI General Medicine, they award MRCPI General Medicine offered in Dublin, Ireland, Muscat, Oman, and all these countries. Medicine of Childhood Pediatrics, it is offered in all these places, Then obstetrics, gynecology, written and clinical exams are offered in Dublin and Oman. Now, then there are diplomas, then faculty examinations are there. Then masterclass series are there. We had a masterclass series in Mumbai also a couple of years ago. And use of technology. Now, here are the international opportunities after the MRCPI. Elective placements, recruitment in certain subspecialties, then and workshops for assessing performance. Now, these are the trainee statistics. I will not go into all that. Now, I'll come to the books which I suggest for the MRCPI course, which I think are very important. Suggested reading: Davidson's Kumar and Clark's textbooks of medicine. Then Basics of MRCPI by Easterbrook. Essential Revision Notes for MRCPI by Philip Calder, published by JP Brothers. An Oxford Handbook of Clinical Medicine. Then Clinic Cases for the MRCPI by Beliga. Cases for MRCPI by Hall. Aids for MRCP Paces, Volume 1 by Banerjee and Mead. Then Clinical Medicine for the MRCP Paces, Volume 1, Core Clinical Skills by Mehta and Iqbal, Oxford University Press. Then Clinical Medicine for the MRCP Paces. This is Mehta, Iqbal, and Bowman. This is again Oxford University Press. Long cases from Harrison's textbook of medicine are important. You can do these long cases like metabolic syndrome, ILD, sleep apnea, valvular heart disease, which are given very well in the Harrison's textbook. Then Clinical Methods by Chamberlain. This is the best book for clinical methods. I think that's what all I in my talk on MRCP preparation. Thank you so much.
Really explain and comprehensive. Not asking.
Anybody who wants to ask any question, any particular doubts from any students, doctors? Any questions? Yeah.
The practical presentations or case presentations in part 3, like clinical presentation, part 2 paper, which things we need to prepare for?
Systems actually, they need to be, you can present cases in the hospital you work there. Of course, in every teaching hospital, these clinics go on, and one must take the opportunity to present a case. Presenting is very important, Unless you present, you will not get the confidence to present the case in the exam, So presenting to your colleagues and presenting to your teachers, will go a long way. Each time choose a different, a system, like once cardiology, once neurology, once endocrinology, once gastroenterology, once respiratory medicine. So keep on. So 5-6 cases, of each system you should present, And once you present, you'll get good confidence and ask people to ask you questions. Asking and answering questions, even if you don't know the answers, even when we were students, I remember, I'll tell you something very interesting. When I was doing my MD, so I went for a clinic in AFMC. I was in BJ Medical College, Pune. So we used to go for clinics there also. So I thought I'll present one case in AFMC, And I got such a big firing from the professor there, I was on the verge of crying, when I came back to the room, I thought, I had not prepared properly for that case. So again, I sat for I prepared things, according to, because there's an examination technique, how you have to present in the exam. So that techniques, maybe I was lacking, So I sat with my friends and we prepared another case to present there. And next time when I presented in the AFMC, that professor, he said, "Are you the same fellow whom I fired last time?" He said, "You're doing so well now. What happened to you last time?" I didn't answer. I said, "So thank you." So it's like that, So unless you discuss and present, you don't learn. Discussion is very important. That silent study does not help. If you read something, discuss with your friends. We used to discuss in the mess while eating a lunch, we used to talk about something, That helped a lot. And I'll tell you the best thing is, if you want to sit for an exam, at least 3 months before the exam, you prepare a small, organize a small group, meet over the weekends and discuss one full system over the weekend, We used to do that. We used to sit whole Saturday night and Sunday whole day. We used to discuss one system. We used to do that 3 months before the exam. We used to start all that. Just one weekend is enough. You sit with all the books in front of you. If there's any doubt, open the book, read aloud to everybody. Everybody learns, and everyone will pass the exam that way.
Thank you so much, sir.
Thank you, sir, for giving such a good enlightenment. Any more questions? I'll be delivering about the clinical examination. We are running short of time. I request to proceed for the. Yeah, as far as any query is concerned or questions are concerned, I request the learned audience to send those queries on our mail, our website. We'll answer those questions. So now we'll proceed for the other topic. Yeah, we'll take a break for at least 2 minutes here out here. Yes, welcome back. Now, the second talk will be delivered by none other than Professor Dr. D.G. Jain. He's going to talk about and enlighten us about the topic which is often most untouched, about the adult immunization. As we all well aware about the pediatric immunization, the purpose for this talk is to emphasize the preventive aspect through immunization. As we all are aware that immunization is one of the greatest discoveries in the mankind. So I would like to put it in that way, that prevention, as what we all know, is better than cure. But if when we add an immunization, we can say that the prevention is cheaper than cure. So today we'll be having a short, brief, and excellent discussion on the practical aspects about the adult immunizations, the efficacy of the vaccines, their indications, their contraindications, and their time schedule. I request Professor Dr. D.G. Jain sir to proceed with his talk.
Thank you, Dr. Tiwari. Good afternoon, friends. The human race has been surviving and succumbing to all sorts of viral, bacterial, and other infections and infestations since time immemorial. Ever since the successful introduction of smallpox vaccination in UK 225 years ago in 1796 by Dr. Edward Jenner, the father of immunization, we have come a long way. The enormous benefits of childhood immunization have guided us to extend these benefits to adults too. In this slide, we see that with the inoculation of mild cowpox protected the patient against the dangerous smallpox. And this was undertaken at a Victorian clinic to reduce the danger of an epidemic in Britain. And here we see mass inoculation of Burmese residents by the Indian Medical Service at the end of the 19th century. Excuse me, this slide is not coming properly on the slide cut raha hai. The last known case of smallpox in India was 24th May 1975. India was declared smallpox free on 5th July 1975, and global eradication of smallpox was confirmed by the World Health Assembly in May 1980. Now, today we are in this new age of discovery. The spotlight focuses on adult immunization, which is like a spider's web. Immunization is meant to catch, contain, and immobilize its prey. In a short span of time, it is not possible to give justice to this extensive topic of preventive clinical medicine. Nevertheless, I will give you a brief glimpse of adult immunization to enable you to gauge its potential and incorporate it in your clinical practice. Tirthankar Mahavir has said that knowledge illuminates all, and Ovid has said that the art of medicine is the question of timeliness. So this is very relevant for immunization. Now, why do you want adult immunization? Because of decline in adult immunity occurs with increasing age. Then there is more susceptibility to infections. Immunization controls morbidity and mortality attributable to communicable diseases, and mortality from vaccine preventable diseases is 350-fold higher in adults as compared to children. Globally, prevention by immunization is always better than cure in the primary management of communicable diseases. Vaccine-induced immunity is neither long-lasting nor broad-spectrum. Immunity declines with time. Therefore, childhood vaccination needs to be bolstered in adulthood to provide lasting protection. Adults act as reservoirs of disease, posing a risk to unvaccinated children, to contacts at home, the workplace, hostels, residential institutions, factories, etc. You may not be aware that India contributes to 60% diphtheria, 40% tetanus, and 44% Japanese encephalitis cases of the world. Increasing susceptibility to infections is seen in international travelers, organ transplant recipients, diabetics, CKD patients, indiscriminate use of antimicrobials, and the emerging resistance, and patients on chemotherapy and radiotherapy. Immunization offers a multitude of benefits to individuals, to families, to employers, to government, and to society. Value of vaccines and immunization is that they save lives, save money. Vaccines and immunization have created a healthier world. Immunization is one of the most successful and cost-effective health interventions. According to the WHO report, out-of-pocket healthcare cost pushes 50 crore people to poverty. The impact of vaccination. With the exception of safe water, no other modality, not even antibiotics, has had such a major effect on mortality reduction, according to the WHO. Immunization of adults is determined by their age, prior immunization status, disease burden in the population, infection trends, mutations in infectious agents, comorbidities, occupation, lifestyle, and travel. Purpose of immunization is to protect by increasing the concentration of antibodies and or effector T cells, which are reactive against infection or cancer. The procedure of immunization is known as vaccination, and the agent for immunization is the vaccine. Immunoprophylaxis is intended to prevent an infection. Vaccination done before exposure is immunoprophylaxis, or soon after exposure to an infectious agent. Immunotherapy is intended to cure the infection or the cancer. It is performed during an active infection or an existing cancer. Immune system confers two types of immunity. One is the innate or the natural or native immunity. Now, this immunity is rendered by the epithelial barriers of skin, the respiratory tract. It prevents the microbe entry, has to be breached for a microbe to establish the infection. Then phagocytic leukocytes, that is neutrophils and macrophages, the natural killer or the NK cells, and circulating plasma proteins, which are most important are the proteins of the complement system. Now, then there is the adaptive immunity or the acquired or specific immunity. Normally it is silent, but it responds to the presence of infectious microbes by becoming active, expanding, and generating potent mechanisms for neutralizing or eliminating the microbes. Components of the adaptive immune system are lymphocytes and the products, and two types of adaptive immune responses are there. One is the humoral immunity, and the other is the cell-mediated immunity, which is conferred by the T lymphocytes or T cells. Immunization mechanisms are passive and active. Passive is the active humoral immunity. It's transferred in the form of ready-made protective antibiotics from one person to another person who is the non-immune recipient. And here immunological memory is absent. But in active immunization, that is the host or the recipient is given a foreign protein or organism in the non-infectious form, in the attenuated form. It induces adaptive immune response, thereby conferring protection and memory also. Vaccines are live and inactivated vaccines. Live vaccines act like a natural infection. They contain the attenuated strain of the bacterium or virus, which replicate in the host. The process of attenuation weakens the bacterium, thereby reducing virulence so as not to cause the disease in healthy people. And live vaccines generate a fairly strong and long-lasting immunity. Live vaccines, there are advantages as well as disadvantages. Advantages are that they produce local and systemic immunity. Single dose is usually enough to induce long-lasting immunity, and they evoke a strong immune response. And the disadvantages are, it is contraindicated in immunosuppressed patients, have a potential to revert to virulence, and possibility of interference by vaccines, passive antibodies, and viruses. And there is always the potential for contamination in the live vaccines, and they have poor stability. Inactivated vaccines are suspensions of whole intact killed organisms like whole cell pertussis, rabies, influenza, hepatitis A. Then there are the acellular and subunit vaccines, which contain one or more components of the organism, and they are important in protection. For example, in acellular pertussis, which has 2 to 5 components of the whole cell pertussis bacterium, then the diphtheria toxoid and the HIV polysaccharide vaccine. Inactivative vaccines have advantages like unable to cause infection. Vaccine constituents are clearly defined and they are stable. Now, disadvantages are shorter lasting immunity, more than one dose is needed, and local reactions are common. Adjuvant is required in the vaccines to keep the vaccine at the injection site and activate the antigen presenting cells. Constituents of the vaccine, these are the constituents, but of course, by reading all this, we can't make our own vaccine. One are the aluminum salts, which enhance the immune response to a vaccine. Then there is a preservatives like thiomersal, which prevents contamination of vaccine by the bacteria or the fungi. Then there are additives like gelatin. Gelatin maintains a vaccine's potency by stabilizing it from adverse conditions, example, freeze drying or heat. Then there are residuals from the manufacturing process. These things are used in manufacturing. Formaldehyde, which is an inactivating agent, and neomycin, streptomycin, polymyxin B antibiotics to prevent the bacterial contamination during the manufacturing process. Then egg proteins, for example, some vaccine viruses are grown in the chick embryo cells, for example, influenza and yellow fever. Then there are the yeast proteins in hepatitis B vaccine. Now, methods of administering vaccines are a few, like oral typhoid vaccines, rotavirus vaccines, and oral vaccines are preferably administered prior to administering injections or performing procedures which cause discomfort. Then there's the intranasal route. Live attenuated influenza vaccine is currently the only vaccine administered by the nasal route. Then subcutaneous vaccines are there. They are injected into the fatty tissue below the dermis. The intramuscular route is there. The intradermal route is there. Then there are combination vaccines. 2 or more vaccines are combined to facilitate the administration of several vaccines in one shot. They reduce the number of infections. And licensing for combination vaccines is a bit strict, Studies are done to know whether they are really effective, and there are not many adverse reactions. Now we have guidelines for vaccination in normal adults. These are the 3 major guidelines. The first one comes from America, from the Centers for Disease Control. The second one is the World Health Organization guidelines. And here we have our own, the Association of Physicians of India Expert Panel Guidelines, the API guidelines. Now, vaccines recommended for all healthy adults are the DPT, MMR vaccine, influenza in people more than 50 years old, pneumococcal in people more than 65 years or less than 65 years who are at risk. Then the varicella vaccine, then the human papilloma virus vaccine between 9 to 26 years, and zoster, herpes zoster, more than 60 years age group. Vaccines recommended in special situations and or high-risk individuals are hepatitis B, hepatitis A, meningococcal, varicella, HIV, typhoid, rabies, cholera, Japanese encephalitis vaccine. These are not routinely used due to lack of adequate evidence. Then there is polio and rotavirus. Now, here are the API guidelines, Association of Physicians of India guidelines. API recommends that routine vaccination in Indian adults should be done for pneumococcal infection, for influenza, human papilloma virus, measles, mumps, and rubella, that is MMR, and diphtheria, pertussis, and tetanus, that is DPT. So these are the 5 vaccines routinely which can be used for Indian adults. Now, DPT vaccine, childhood vaccination does not confer lifelong immunity. Majority of cases of DPT are seen in India. Single dose of DPT, which is also known as the triple antigen vaccine, followed by a booster every 10 years, provides adequate protection in previously vaccinated subjects. Now, full dose diphtheria, tetanus, pertussis vaccines are used regularly in children. They are on the National Immunization Program. I will not go into all these details now. Now, in adults, for adults between 18 and 64 years who have completed their primary vaccination, a booster dose of tetanus diphtheria vaccine is indicated every 10 years till age 65. 1 dose of TDAP, which also includes pertussis, may be administered in place of TD vaccine. That can also be done. For adults more than 18 years who have not received prior vaccination against DPT, 3 doses of the tetanus and diphtheria vaccine are indicated. 2 doses are administered at least 4 weeks apart. Third dose is given 6 to 12 months after the second dose. For adults who have not received this vaccine and are likely to come into contact with infants suffering from diphtheria or pertussis, a single dose of this vaccine should be given at least 2 weeks before contact with the infant. Now, healthcare personnel and those in direct contact with patients should get this vaccination. Women planning pregnancy should receive 1 dose if they did not receive it previously. And pregnant women who have received this vaccine more than 10 years ago should receive again 1 dose in the 2nd or 3rd trimester of pregnancy. Pregnant women who have received the tetanus and diphtheria vaccination during preceding 10 years should receive 1 dose of this vaccine immediate postpartum period. Now, pregnant women who have never received previous vaccination, 3 doses are required, And following minor trauma also in non-immunized individuals or those immunized 10 years ago, this vaccine is given. PIG is not required. And in post-transplant patients, modified dose vaccine is not effective. Full dose is needed. Now, there are some precautions also. This vaccine DPT is contraindicated for persons with a history of anaphylaxis to any component of the vaccine. It is contraindicated in adults with history of encephalopathy not attributable to an identifiable cause within 7 days of administration of a vaccine with the pertussis component. These persons should receive TD vaccine. In adults with moderate or severe acute illness and those with unstable neuro conditions like stroke, acute encephalopathies, the TDAP vaccine is deferred until the acute illness resolves. In adults with a history of arthritis reaction with the previous dose of tetanus or diphtheria containing vaccine, TDAP or TD is administered only after 10 years since the last dose. Now, coming to MMR, there are 55,000 cases of measles, that is rubella, and 1,000 cases of rubella, German measles, reported from India in 2018. 16% Indians are susceptible to rubella, German measles infection. Mumps is caused by the RNA virus, myxovirus, pericarditis. Outbreaks in India have been reported mainly from the hostels, colleges, etc., poor socioeconomic settings. And dose of MMR triple vaccine is a single dose in previously immunized individuals and 2 doses at intervals of 1 to 2 months in non-immunized persons. It provides enough protection. Now coming to the influenza vaccine, it provides adequate protection against H1N1 infection, reduces cardiac mortality up to 45%. Antibody monitoring is not required and indicated in all high-risk subjects. There's a big list of these high-risk subjects. Then influenza vaccine is available as trivalent, that is 2 strains of influenza A and 1 strain of influenza B. Then quadrivalent, 2 strains of influenza A plus 2 strains of influenza B. Then there's a live attenuated lyophilized nasal spray vaccine also. Side effects are allergic reactions, Guillain-Barré syndrome. Then contraindications, again, high-risk individuals should not receive nasal spray live flu vaccine. Influenza vaccine is available in India as a killed virus vaccine and is administered intramuscularly in a dose of 0.5 ml into the deltoid muscle. As the influenza virus constantly mutates, a new batch is prepared every year. Vaccine becomes effective against the influenza virus only 2 weeks after its administration. Since the peak influenza season begins in October and lasts till May, October, November are the best times to receive this vaccination. Now coming to pneumococcal vaccination, it prevents pneumonia and invasive pneumococcal disease because there is 28% mortality in more than 50 years or elderly and immunocompromised adults. And this is important to counter the emerging resistance to penicillin and macrolides, which are used so extensively, to reduce mortality in high-risk groups less than 50 years of age, like chronic heart disease, lung disease, etc. Now, pneumococcal vaccine is available in 2 forms, polysaccharide vaccine and the conjugated vaccine. Polysaccharide vaccine is approved in the US, European Union, India for use in adults more than 50 years for prevention of pneumonia or invasive streptococcus pneumonia serotypes. In immunocompetent adults, a single dose of PPSV23 is indicated in those over 65 years to be repeated every 5 years. Vaccine is also indicated for those with CKD, COPD, cirrhosis, diabetes, HIV, lupus, cancer, those on chemotherapy, radiotherapy, long-term steroids, or splenectomy. A single dose of this PPSV23 is recommended in immunocompetent adults. And in those who have not received primary vaccination, PCV13 can be given, followed by PPSV23 after a minimum interval of 8 weeks. Now, for the pneumococcal vaccine, the advisory committee of CDC says that routine use of PCV13 among adults more than 65 years in high-risk adults more than 19 years is needed, and it is recommended interval for adults receiving PCV13 and PPSV23 to be at least 1 year apart, regardless of the sequence. And now coming to the human papilloma virus, it is the second most common cause of cancer, second leading cause of mortality in India. Cervical cancer is the 4th most common cancer in women. HPV is the leading cause of 90% of cervical and anal cancers, 70% of vulval and vaginal cancers, and 60% of penile cancers. 77% of cervical cancers in India are caused by HPV serotypes 16 and 18. India has a complicated history with cervical cancer. I will not go into the details. Now, WHO take on cervical cancer is this, that there are more than 5 lakh new cases of cervical cancer every year, 2.5 lakh deaths annually. India accounts for a quarter of these. Nearly all cases of cervical cancer are linked to the HPV virus passed through intimate skin contact. Most sexually active women and men will be infected with HPV and often reinfected at some point in their lives, most likely around the time of their first sexual experience. Majority of HPV strains do not cause symptoms or health problems and clear up within 2 years. Persistent infection with specific types of HPV can lead to cervical lesions, which may progress to cancer. other types of HPV that can cause genital warts and rarer diseases like anal cancer. In December 2017, the National Technical Advisory Group on Immunization, which is the Government of India's highest advisory body on immunization, had recommended that HPV vaccine be introduced into India's universal immunization program. However, that did not happen. In accordance with the recommendations by the WHO, girls be vaccinated between the ages 9 to 14, and goals should be to introduce the HPV vaccine countrywide. But it's an expensive vaccine, so it has not yet been included. Now, human papilloma virus vaccine, why is it important? It protects against everything that is responsible, this virus, which causes cervical cancers and genital warts. It is most effective when administered before the onset of sexual activity. It's a very important point. HPV vaccination can be given to young males and females between the ages 9 to 26. I won't go into the dosing. Now, coming to the varicella vaccine. Chickenpox and herpes zoster are now regarded as different host responses to the same etiological agent, that is varicella zoster virus. Incidence and severity of herpes zoster disease increases with the age, with marked increase after 50 years due to the aging-related decline in cell-mediated immunity. During 2013, there were 28,090 cases of chickenpox, with 61 reported deaths, and case fatality rate was 0.21%. Kerala reported the highest number of cases, and West Bengal reported the maximum number of deaths due to chickenpox. Transmission of varicella is by droplet infection. Incubation period is 14 to 16 days, that is 2 weeks. There are 2 vaccines for varicella. All adults who have never had chickenpox should receive 2 doses subcutaneously in the deltoid region. For less than 13 years of age, first dose is given at 12 to 15 months and second at 4 to 6 years. For those already immunized, booster doses are not needed if titers are adequate. Varicella vaccine should not be administered to people who are on high-dose systemic immunosuppressive therapy, including oral corticosteroids, HIV seropositive adults or adolescents with CD4 plus T lymphocyte count less than 200, persons with a family history of congenital or hereditary immunodeficiency in first-degree relatives. Varicella vaccine is contraindicated in those with gelatin allergy and neomycin allergy, and people on radiotherapy and chemotherapy, and people who have received blood products or transfusion during the past 5 months. Now coming to the hepatitis B vaccine. It causes about 30% of cirrhosis and 50% of hepatocellular carcinoma. Indications of vaccine are the high prevalence of chronic hepatitis B carrier state in the community, which increases the risk of transmission. There are 3 doses, 20 microgram intramuscular, 0, 1, and 6 months. Booster dose not recommended in immunocompetent adults. It is a recombinant vaccine. Plasma-derived vaccine is not used due to risk of transmission of infections. Now, indications for hepatitis B vaccine are many. I will not go into all that. Now, hepatitis B vaccine, pre-vaccination screening in general population is not cost effective. It is not required. Now, coming to the hepatitis A vaccine. Hepatitis A virus causes about 30% of acute hepatitis and 15% of acute liver failure. Its indications for vaccine are kidney liver transplant candidates with chronic hepatitis B or C to decrease the risk of fulminant hepatic failure. Patients of CLD, other hepatitis, virus infections, recipients of blood products, clotting factor concentrates, illicit drug users, homosexuals, animal handlers. 2 doses given at 6 to 12 months interval. Combination vaccine for HAV and HBV can also be given. There are 3 doses for that. Now, this is the inactivated hepatitis A vaccine. Now, universal immunization for hepatitis A is not recommended. Groups of adults at high risk for acquiring hepatitis A, they all need this vaccine. Now, coming to the meningococcal vaccine, there are 3 types of meningococcal vaccines available. 2 are the quadrivalent vaccines, and they contain 4 antigens, and 1 is the bivalent vaccine. It has only 2 antigens. The 2 types of quadrivalent vaccines available are the meningococcal polysaccharide vaccine, and 1 is the meningococcal conjugate vaccine. Meningococcal polysaccharide vaccine does not induce herd immunity, whereas the meningococcal conjugate vaccine provides herd immunity. Now, quadrivalent and bivalent vaccines do not protect against meningococcus P strain or meningitis due to other organisms. And this conjugated vaccine is preferred for adults more than 55 years or younger, as well as for adults aged 56 or older who are vaccinated previously with MCV4 and are recommended for revaccination. MPSV4 is preferred for adults more than 56 years or older who have not received it previously and who require a single dose, example, travelers. The indications for meningococcal vaccine are special situations such as during an outbreak. Single dose of vaccine may be given to healthcare workers, lab workers, close contacts of cases, and all people living in dormitories and jails and hostels. They all need it. And travelers need a single dose, which is recommended 10 to 14 days before the scheduled visit, depending on the prevalent serotype in the visiting country. The National Institute of Communicable Diseases in New Delhi administered the quadrivalent polysaccharide vaccine, that is MPSV4, to all Hajj pilgrims. Now coming to the HIV vaccine, which is a Haemophilus influenza B vaccine. Vaccination is part of the primary immunization. Adults at risk who should be vaccinated are patients with asthenia, HIV, hematological malignancies, corticosteroid use, CSF leak, trauma, diabetes, pregnancy, and all that. Dose is a single dose, 0.5 ml of the conjugate vaccine is administered intramuscular. Coming to typhoid vaccine, which is available as inactivated whole cell vaccine, live oral, injectable, VI polysaccharide vaccine, and VI REPA vaccine. The live oral typhoid vaccine is available in two formulations, liquid suspension in sachets or enteric-coated capsules. The VI polysaccharide vaccine is a subunit vaccine composed of purified VI capsular polysaccharide. This is the typhoid polysaccharide vaccine, which is used in India and available. Now, typhoid vaccine, there are 3 doses of the oral vaccine which are administered on alternate days. Indications are entire community at risk should be vaccinated only during an outbreak, and this vaccine cannot be used during pregnancy. And live oral typhoid vaccine is contraindicated in transplant recipients. Now coming to the rabies vaccine, the sheep brain-derived nerve tissue vaccine, previously known as sample vaccine, is no longer used. These days we use the tissue culture vaccine such as human diploid cell vaccine, purified chicken embryo cell vaccine, and newer and less expensive vero cell purified rabies vaccine, which are available. They are easy to administer, highly immunogenic, and have a good margin of safety. TCV are used for pre and post-exposure prophylaxis. The pre-exposure schedule for the rabies vaccine is 3 doses at days 0, 7, and 28, given only to the high-risk groups, and administration of the deployed human deployed cell culture vaccine and purified chick embryo cell culture vaccine, that is 1 ml intramuscular in the deltoid or anterolateral thigh. Purified vero cell rabies vaccine is 0.5 ml, again intramuscular in the deltoid or anterolateral thigh. Now, monitoring is antibody titers can be done every 6 months, but only in persons who are working with live virus in diagnostic or research facilities. Booster dose if the titers fall. Now, this is very important from the clinical point of view, clinical practice. Post-exposure prophylaxis. Person comes to you with a dog bite. A person who is exposed and has never been vaccinated against rabies should get 5 doses of rabies vaccine at 0, 3, 7, 14, and 28 or 30 days. Exposed person should also get human rabies immune globulin, which is 20 international units per kg body weight, but up to a maximum of 1500 units at the same time as the first dose. And previously vaccinated person should get 2 doses of the rabies vaccine on day 0 and another on the 3rd day. When needed, rabies immunoglobulin should be infiltrated as much as possible into and around the wounds, and the remaining should be given intramuscularly at a site away from the site where the vaccine has been administered. Now, management of re-exposure. On re-exposure, if the dog bites again after 1 or 2 years, 2 booster doses, that is on day 0 and 3, irrespective of category of exposure or time that has elapsed since previous vaccination. All subjects who have received incomplete vaccination should be treated as fresh cases. In case, rabies immunoglobulin is not available and it's a category C bite, then double dose of the first dose of vaccination may be administered in the following situations. category 3 exposure, and patients who are malnourished on corticosteroids, anti-cancer drugs, etc., patients with HIV, AIDS, etc. If feasible, antibody titers should be monitored and boosters given if titer is less than 0.5. Immunosuppressed patients should avoid activities for which rabies pre-exposure prophylaxis is indicated. Coming to the cholera vaccine, available as injectable killed whole cell vaccine, has a poor efficacy, short-lasting protection, not recommended. Oral cholera vaccine is Dukoral, approved for use in persons more than 2 years of age. 3 separate doses are there, and 2 doses are there for those who are more than 6 years old. Confers 80%, 85 to 90% protection for 6 months only among all age groups, which it declines after 2 years. Now, Japanese encephalitis virus. It is a mouse brain-derived inactivated vaccine. However, with effect from 2007, its production has been stopped. Now we have the cell-cultured live attenuated vaccine. Dose is a single dose of 0.5 ml with a booster dose at 1 year. The JE vaccine is primarily useful only in the pediatric age group. The issue of adult immunization against Japanese encephalitis is still needs to be reviewed. Now coming to yellow fever, because if you go to certain countries, you may need this vaccine. Yellow fever is a zoonotic disease caused by an arbovirus. Monkeys and other vertebrates are affected in tropical America and Africa. It is transmitted to man by certain culicine mosquitoes. It's a very dangerous fever, causes severe hepatic and renal involvement with jaundice, hemorrhagic manifestations, anuria, shock, stupor, coma, and death occurs between the 5th and 8th day of the illness. So if you go to these countries, you must get this vaccine. Vaccine is used for immunization against yellow fever, is live attenuated vaccine, and it is administered as a single 0.5 ml dose. Protection effect of vaccination starts from the 10th day and lasts up to 10 years. Now, what is adult immunization? It's a question of awareness, affordability, and accessibility. Now, I will briefly, just to wrap up this whole talk, I'll just revise the recommended immunization schedule for adults with normal immune status. First is the influenza vaccine, then the streptococcal pneumonia vaccine, Then we come to the human papilloma virus vaccine, then herpes zoster vaccine, then DPT vaccine, and the MMR vaccine. Now, coming to the adult immunization in special situations, there you need hepatitis A, you need hepatitis B or hepatitis A plus B, you need typhoid, you need the cholera vaccine, you may need the meningococcal vaccine, the varicella vaccine, the HIV vaccine, sometimes rabies vaccine, and sometimes the Japanese encephalitis vaccine. Polio, like, in Britain, they have recently detected cases of polio. So if you go to, one goes to UK, you may need this vaccine also. Then rotavirus. Finally, superior doctors prevent the disease, mediocre doctors treat the disease before it is evident, and inferior doctors treat the full-blown disease. So this is a Chinese saying. And before I end, I'll just say one thing, that adult immunization, at the end of the day, adult immunization has to be tailored as per an individual's need and health profile. And this is exactly what you have to do. I am reminded of a wise teacher who said, the human mind is like a parachute. It works only when it is open. And the time now has come to step up awareness and educate people regarding the benefits of immunization, and scientific and technological research and development of vaccines needs to be strengthened further. By medicine, life may be prolonged, yet death will seize the doctor too. This was written by William Shakespeare. So don't stress, just relax, and thank you. And make sure that you get immunized properly and live a full, healthy, and hearty life. Thank you.
Thank you, sir, for giving such a good information about the adult immunization. It's not just the information, but in-depth idea about how to vaccinate the individual, the indications, contraindications. Thank you, audiences, for your kind listening. I think it's almost 2:15 by now, and I think we should proceed for the lunch first, and then we'll continue with our sessions post-lunch. So I request everyone to join for the lunch session right now. We'll start in the next 30 minutes after the lunch. Yeah. Thank you. next eminent speaker is Dr. Manoj Chadha, sir. Let me introduce you, sir, as MD and DM in endocrinology. Presently, the sir is a consultant endocrinologist at PD Hinduja Hospital, Mumbai, Hope and Care Center at Navi Mumbai. As far as the teaching experience is concerned, sir is a DNB endocrinology teacher since 2008. He has been ex-faculty in endocrine department at KM Hospital and BL Nair Hospital and TN Medical College, Mumbai. He is trained in the use of artificial pacemaker from Germany. He is the past president of Endocrine Society of India in the year 2017 and 18. He is a past president of Indian Society for Bone Mineral Research in the year 2015 and 19. And he's a member of the Asia Pacific Region Committee of IOF. I request Manoj Chadha, sir, to please deliver his talk and enlighten us.
Okay. Thank you, Avilash, and I'd like to thank the RCPI for inviting me for this interesting program. And could I have my slides so that we can get on fast? So thyroid disorder, I think everyone needs to think of thyroid when they find routine symptoms and then they find certain odd things. So what 25 minutes or so is give you an overview of what your the pointer doesn't, the thing doesn't seem to be working, or you can just keep doing forward when I tell you. So I have put here certain information which probably in 20-25 minutes is okay. Otherwise, we'll be trying to cover up too much in too little time. Yeah. So the common presentation is either a swelling in the neck. So we see a lot of patients going to ENT surgeons. Unexplained weight change. So please note that I'm putting emphasis on the word change because it could be weight gain or weight loss. Swelling on the body, lethargy, hair loss. Again, change in appetite, bowel habits, and sleep pattern. Recently, I was invited by the GI group to take a talk on thyroid and GI disorders, and I learned a lot of interesting things. But I remember my gastroenterology colleagues used to send a lot of patients to me with change in the bowel habits. Change in voice, easy fatigability, paresthesia, joint bone pains, menstrual disturbances, infertility, bad obstetric history. Basically, what I've covered in these two slides is that every organ system can be affected because of thyroid dysfunction. We know that thyroid hormone affects each and every organ system, right from birth till the last days. And we have to keep thinking of thyroid disorders in practice. Very quickly, if we look at this axis, in endocrinology, you have the end organ, which is controlled by a superior organ through a stimulating hormone. So here in thyroid, you have the hypothalamus and the pituitary, which controls the thyroid hormone, the thyroid gland. And the thyroid gland produces T4 and T3, which feedback on the hypothalamus and the pituitary to tell that this is enough. And that is how the homeostasis is maintained. For some reason, if the T4, T3 starts falling down, this negative feedback goes down and the TSH starts increasing. So which is what you see in hypothyroidism. And the reverse, for some reason, if the T4, T3 starts increasing in the blood circulation, the negative feedback increases and the TSH production goes down. But since we are dealing with an autonomous state, the thyroid goes on producing T4 and T3. So T4, T3 go up and TSH goes down. So it's very simple in a way in endocrinology. The target hormone goes up, the stimulating hormone goes down, and the target hormone goes down, the stimulating hormone goes up. When you see or you're thinking about thyroid, there are two things in mind. One is an anatomical diagnosis. Either there is no goiter or a diffuse goiter, a solitary nodule or a multinodular goiter, because each one has its own implications. And physiologically, you should also classify, is the patient euthyroid or hypothyroid? And then if you notice, I have not used the word hyperthyroid right away. I've said thyrotoxic stroke hyperthyroid. So one of the important parts of my talk is to understand the difference between thyrotoxicosis and hyperthyroidism, because a lot of students, a lot of physicians still make a mess about these two terms. I'm going to cover up probably hypothyroidism, thyrotoxicosis, thyroiditis, and subclinical thyroid disorders. Pregnancy and nodules would be some other lecture some other day. A 45-year-old female with unexplained weight gain, dry skin, hair loss, irregular menses, swelling of the face on getting up from sleep. So really, this is a very straightforward case and no extra marks for guessing what we are looking at. Bradycardia, normal blood pressure, dry skin. I have put very abnormal reports just to highlight the case, but in practice, you may not get a T4 of 1.2, you may get a T4 of 3, 4, 5, a T3 which may be low normal or even bang normal, and a TSH which could be anything between 10 and 100 or 500. So these are all possibilities, but just to keep in mind. Anti-TPO and anti-thyroglobulin antibodies, these are two tests which don't need to be done in each and every hypothyroid patient. These are expensive tests and they really do not add any additional value except for the fact that they say that this is autoimmune thyroiditis as the cause of hypothyroidism. They don't decide the treatment. They don't decide the dosage of thyroxine. So please don't write this as a routine for every patient. The reason I put that is not to say that you should do it. I'm telling you, don't do it unless you have certain doubts, which I'll discuss in the subclinical cases. Similarly, an ultrasound has to be done only if there is a doubt in your mind. If there is no goiter, there's a diffuse goiter, please don't bother doing an ultrasound. And the same thing applies for thyroid scan. For all practical purposes, a useless investigation, again, in selected cases should be done. The treatment, once you made the diagnosis, is very straightforward because unlike so many other diseases, you don't have 6 drugs to choose from. You have only one drug. There may be 6 companies, but thyroxine is the only drug. It has a long half-life, nearly 1 week. It has to be taken daily single dose on empty stomach. Please note that I tell my patients, now we have about 8 different strengths. Good old days, 30 years ago, there was only one strength of 100 micrograms, and we had to titrate the dose depending upon the number of tablets per week. Thyroxine dose is decided by the weekly dose, and the extension of this is if patient forgets to take 1 dose for some reason, they can take a double dose next day. T3 is not indicated for routine management, although now some countries, especially UK, Italy, and some other European countries have started using T3 as routine. But for practical purposes, today as we talk, T3 is not indicated routinely. The average dose is 1.7 microgram per kg body weight for adults. Children actually require a higher dose per kg body weight. So very often you may find that you are starting with nearly the same dose, whether it's an infant, a pubertal child, a young adult, or an old adult. Young adults, we can go a little more aggressive. The older adults, the geriatric population, we go very slow and we don't increase the dose at least 6 to 8 weeks. Yeah, so the determinants, as I said, age is one thing. Underlying cardiac disease, you have to go very slow. If there are other drug therapy, especially the PPIs and the chelating agents, that is why thyroxine has to be given on an empty stomach. Young adults, you can start with full dose. Long-standing disease, elderly, ischemic heart disease, you could start with 25 micrograms a day or sometimes even with 12.5 micrograms. Don't check the T4 levels or TSH levels every 2-3 weeks. Give it 6 to 8 weeks because TSH takes at least 6 to 8 weeks to normalize. And once it is stable, you could check up every 4 or 6 months or even once a year if the patient comes from far off. You don't have to call them every 2-3 months. Fortunately, allergy to thyroxine or failure to respond is very rare. And we keep that for some other day. What are the situations? We change tracks, go to the other side of the spectrum. 55-year-old male, again, unexplained weight loss. So nowadays, there's a fad for losing weight rapidly, different diets. So those are not then to be treated as thyroid patients, but unexplained weight loss in the last few months, palpitations, tremors, stress in the family, family history of thyroid disorder. So what I've tried to give you here is the common history and the common symptoms that you should ask in your thyroid patient. Tachycardia, white pulse pressure, warm, moist palms. These are all features of toxicosis. Again, very high T4. Just for the record, normal T4 in most labs is 4 to 12 microgram per deciliter. T3 is 360, a normal. I remember it as 100 to 200 because it's easier. And TSH is normal is 0.5 to 5. So here it's 0.05. So we know that this is definitely thyrotoxicosis. Again, I put these investigations not to say that they have to be done in every patient, but only in selected patients. Anti-TPO, sonography if you're suspecting a thyroid nodule or a multinodular goiter, and thyroid scan also in very selected cases. See, the thing is, most of the patients have got either Graves' disease or a nodule. So it's easy to make your clinical diagnosis and treatment can then follow. So that's how a scan looks in Graves' disease or any hyperthyroid patient. And that's how a hot nodule would look. So the management is pretty straightforward. Once you have a diagnosis, you have an option between medical management, surgical management, and radioactive iodine. If you had asked me about 4 or 5 years ago, I would have put the order of management as radioactive iodine, medical management, and surgery as last. But somehow over the years now, medical management has come up as number 1 and pretty long term. We used to talk of 12 to 18 months. Now we are talking of 5 to 10 years also if necessary. So it's pretty safe and that's why it's come up. Surgery has gone down in order of importance, probably not that we don't have good surgeons, but we can do without surgery in most patients. But if it's a very large goiter, if it's a goiter which is increasing in size, if it's a patient who has relapsed after medical management, or young patients planning for surgery, for pregnancy, then surgery is a good option. I was trained in a center where radioactive iodine was the preferred line of therapy. Still, a one-shot treatment, pretty safe and works in practically most patients. So we still keep the radioactive iodine as a good option. And I give my patients all 3 options. A little diversion used to be a rare case, but after COVID, now we have started seeing this quite often. Young patient or middle-aged patient, it doesn't matter, age is not a criteria. But unlike the regular thyrotoxicosis patients that we were seeing, now patients come with a shorter history, couple of weeks, not couple of months. The important thing to keep in mind is weight loss and all the other things, palpitations and tremors and behavioral changes, not sleeping well. But they give you history of fever, evening rise of fever. Now, those who have been trained in India, the first thing when you hear evening rise of fever is tuberculosis. So keep that at the back of your mind. But remember, if there is a patient complaining to you of pain in the throat and pain radiating from the throat up to the ears, your antenna should go up. Because this patient may have a flu-like illness a few weeks ago, and really there is no family history of thyroid disorder. I'm sure most of you have guessed what way I'm leading to. But if you were to examine this patient, you'll get a toxic patient, exquisite tenderness on certain points of the thyroid gland. If you look at their ESR, it is generally 100 plus. Very few conditions in medicine today are associated with an ESR of 100 plus. See, ESR of 40, 50, 60, 70, there may be hundreds of conditions, but ESR 100 plus, very few conditions. I think you could count it in probably the fingers of one hand itself. TSH, T4, T3, it's become fashionable to ask for free T3, free T4, but I'm still of the old school of thought that doing a T3, T4 is a better investigation. And in this situation, it is the investigation to do. I'll tell you why. Antithyroid antibodies, anti-TPO and ATA will be negative in these patients. So it has a diagnostic value when it is negative. Sonography here may be useful because they have got typical features of this condition on sonography. And FNAC here is purely a academic tool, not indicated in most clinical practice. But a thyroid scan, so I made a statement a few minutes ago, thyroid scan is useless in most thyroid disorders. But this is one condition where the thyroid scan is diagnostic. And if you look at the thyroid scan, you will see no activity. The thyroid has been damaged because of thyroiditis. So we call this subacute thyroiditis. There is no activity in the thyroid gland, and all the stored thyroid hormone from the gland and from the colloid has come into the circulation. I made a statement, asked for T4, T3, TSH, because in a normal toxic patient, the T3 production is more. So if you were to take a ratio of T3 to T4, it will be more than 20. T3 in the nanogram per deciliter and T4 in microgram per deciliter. And if you took the ratio, it comes as more than 20. But if you were to do it in subacute thyroiditis, because it is the stored hormone which is thrown out, the T3, T4 ratio becomes less than 20. As a matter of fact, T4 will be 17, 18, 19, 20. And T3 may be just 200, 220, 230. And that is one of the other indicators of telling you that you're dealing with subacute thyroiditis. So why did I make this statement in the beginning that hypothyroidism, there is only one term, whereas here we sometimes use thyrotoxicosis, which is the right term, and sometimes we use hyperthyroidism, which may be the right term in certain situations. So as you can make out, the first case I showed you was thyrotoxicosis and hyperthyroidism, whereas the second case I showed you was thyrotoxicosis without hyperthyroidism. The thyroid scan you saw was zero activity. So now you understand that thyrotoxicosis is the syndrome of hormone excess. When we have increased T3, T4 in the circulation, you have typical clinical features, that is thyrotoxicosis. And when you have a feature of refuses to come, can someone help me there? Yeah. Okay. So when there is evidence that there is ongoing thyroid hormone production, that means the gland is producing hormone, then we use the word hyperthyroidism. If the patient is taking extra tablets from outside, we call it as iatrogenic thyrotoxicosis. We don't call it hyperthyroidism. If the patient has subacute thyroiditis, the gland is inflamed, the hormone is thrown out, we call it thyrotoxicosis. And you understand the difference because hyperthyroidism is treated with antithyroid drugs. It is treated with radioactive iodine. It is treated with surgery. Whereas thyrotoxicosis without hyperthyroidism is treated symptomatically. You need to buy time, the patient recovers. Very often, when in clinic, I tell my patient that you have a disease called time pass disease, and whether you come to me or not, you are going to get okay. Okay, can you push it next? So the management of subacute thyroiditis is symptomatic. We use either non-steroidal anti-inflammatory agents, and in selected cases, it's not moving. Please help me on that. In selected cases, we use steroids. Beta blockers, again, for taking care of the tachycardia, palpitations, tremors. There is no role for antithyroid disease drugs. And generally, in the first 4 to 6 weeks, these patients do recover. Sometimes the course may be protracted. A subset of these patients may go into hypothyroidism. And at that time, they need regular treatment with thyroxine. But the important thing is it's a self-limiting disease. Between 6 to 9 months down the line, most patients recover. Okay. Let's go to the other thyroiditis, which is very often missed out, and that's called postpartum thyroiditis. As the name indicates, it's in the first few weeks after pregnancy. This may also follow a triphasic response, toxicosis, followed by hypothyroidism. Here, it is a autoimmune process. The antithyroid antibodies do rise. It is seen very often in patients with type 1 diabetes going through pregnancy, and it is known to recur in future pregnancy. So that's the difference between postpartum thyroiditis and subacute thyroiditis. Okay. Yeah, so let's. Now, quickly, in the last part of my talk is the subclinical thyroid disorders, which are now very common in practice, and I find a large number of patients are unnecessarily treated. So perimenopausal, menopausal lady with or without swelling, putting on weight unexplained. The patient is very clear that they have not changed their diet. Their activities are about the same. And so this one I put here is straightforward hypothyroid patient. But can someone put that next slide, please? Yeah. So this is what I'm trying to say, that TSH is, the 5, 6, 7, 8 range. Weight gain, some amount of swelling on the face in getting up in the morning, the rings become tight, and you're thinking that, oh, this is definitely hypothyroidism. There are very clear-cut guidelines on when these patients should be treated. The bigger problem is she started on thyroxine, the numbers start improving, but there is no change in the original complaint. So you just go on stepping the dose of thyroxine, and what you end up is 50, 75, 100. The TSH goes down, and eventually you have a condition of iatrogenic thyrotoxicosis. But that original complaint of the swelling in the face or the lethargy or the heaviness of the body still continues. So please understand that if you do want to give thyroxine for a short period, it should be 50 to 75 micrograms. It should be for a finite period. And if the patient is not better in 3 to 4 weeks, please agree that you have made a diagnosis which is not correct, and you need to think of another diagnosis. So that's subclinical hypothyroidism. And I think I have a slide here which tells you when you should treat it. Can you put the next slide, please? Next slide. So the condition where you would treat your subclinical hypothyroids are if there is a family history of thyroid disorder, if there is a goiter, if there is anti-TPO which is positive, if you have earlier reports and show that there is a rising level of TSH, if there is a young patient, if there is a young lady planning for pregnancy, or if the lady is already pregnant, then these patients have to be treated with thyroxine. There is no two ways about it. Otherwise, especially the perimenopausal, menopausal age group, you can wait for 2 months, you wait for 4 months, you wait for 6 months. There is no harm that is going to be done to your patient. You may be actually doing good for them, because 1/3 of hypothyroid patients, of subclinical hypothyroids, actually revert to normal with time. 1/3 will remain subclinical hypothyroid, and you can just give them symptomatic treatment. And it is only 1/3 of these patients who actually benefit with treatment with thyroxine. The last part is subclinical hyperthyroidism, which is not as common as subclinical hypothyroidism. But in the postmenopausal ladies and in the elderly males, you may need to treat a low TSH with normal T3, T4. If you are dealing with a young patient with normal T3, T4 and a low TSH, again, a wait and watch policy is much better than trying to rush into anti-thyroid drug treatment, because that is more likely to harm them. I think I have sort of gone through most of my slides even without seeing them. So thyroid disorders are common, and you must think of it in practically every scenario. Today, doing a TSH is as simple as doing a CBC or sugar. And I think you can get value for your money in that. Hypothyroidism should be treated judiciously with thyroxine in as small a dose as possible. Hyperthyroidism is treated with anti-thyroid drugs. Where indicated, we go for radioactive iodine or surgery. Graves' disease is the commonest cause for hyperthyroidism, whereas you also have nodular goiters, multinodular goiters there. Subacute thyroiditis has increased ever since this COVID pandemic has come in. You must think of that, because that is a thyrotoxicosis which does not need anti-thyroid drugs. Postpartum thyroiditis is seen in about 8 to 10% of pregnancy patients. It's again self-limiting and very often missed out. Patients, I mean, the doctors keep thinking about postpartum depression and they forget and they miss out this postpartum thyroiditis. And as I said, finally, subclinical thyroid disorders are common. Please be very judicious in deciding about your treatment. I'm going to end now. Thank you very much. And if there's some questions, I'll be happy to take them.
Thank you very much, sir, for giving a very good information in regards to the management of thyroid disorders. Any questions from the audience? Yeah, there's a question out there.
Dr. Jeddah, we have seen many times the same dose of eltroxin, the patient's values change very rapidly, especially in young patients. The TSH varies. And whatever little adjustment you do, either you end on overcorrecting it or undercorrecting it. So what is that situation? That time, is it better that you keep quiet and watch the pattern for 6 months and then change the dose? What should be our proactive approach?
I think first thing is most patients, you wait for 3 months before you decide to make a change. Number one. Number two, small changes in your reading, especially if the T3, T4 are in the normal range and the TSH has gone up a little or gone down a bit, don't jump to correct it every time. Give it some time and most patients would come back to normal. A variation in their dosage, having missed out few doses could be also responsible for this. And since this is an autoimmune thyroiditis, very well known that the doses may vary. That's why we say once in 6 months to once a year, you must call these patients back for a follow-up.
Yes, sir. Any more questions? Yeah.
Not a question, just a comment. The sort of target TSH that we set for an individual undergoing the treatment, this is something which is very much dependent on the age. For example, in the very elderly people, a target TSH of maybe 3 or 4 may be a bit too much of an overcorrection. In fact, there have been several studies which have shown that a TSH of maybe 6 or 7 in somebody who's 75 or 80 years of age would be probably just the right thing, and you probably do not need to correct it at all. Your comments on that?
Absolutely. Actually, there are studies now which say that in the 85, 90-year-old, if your TSH is above 10, you live longer. So most patients above, if the TSH has gone above 10, will require treatment. But if you're dealing with a, say, 80, 85-year-old, I would wait for maybe even 12 or 15 if the patient is otherwise asymptomatic. You don't have to rush to treat the TSH there. It's the T4 and the T3 which keep the patient under control.
Thank you, sir. We'll just wait for a moment to arrange another laptop out here. Akshay?
That's fine. Fantastic.
Yes, good afternoon, friends. Next speaker is Dr. Sujay Mujumdar. And I'd like to give a brief introduction. Sir is an MD, MRCP, FRCP Dublin, FRCP London. He has done his MAs in USA Gold Medal in MD General Medicine. He is honorary head of Department Diabetes and Endocrinology at GD Hospital and Diabetes Institute at Kolkata. Senior visiting consultant endocrinologist at Peerless Hospital located at Kolkata. He is the Vice President of Diabetes Awareness and U Day, Faculty of Certificate Course in Evidence-Based Diabetes Management. He is an examiner for MRCP Ireland, clinical examinations in India as well. Presently is the Vice Chairman of Indian chapter of the Royal College of the Physicians of Ireland. He has, to his credit, around 26 publications in national and international journal. One chapter on acromegaly and diabetes in Diabepedia, on online textbook on diabetes. He has even shared his few articles in the European Association for Studies on Diabetes. He has contributed various chapters in the textbooks like Macmillan Medical Communication, 2 chapters, case studies in diabetology, 1 chapter in analog insulin, Presently is a joint editor and author managing diabetes and endocrine conditions, a case-based comprehensive approach. He's a reviewer of diabetes medicine, diabetic medicine, BMG Journal, Diabetic Research and Clinical Practice. I request Sir to begin his talk.
Right. Thank you, Vilash, for such kind words. And without wasting much words, because we are running short of time, I'll just get on to the main topic of discussion today. So basically, whenever we are talking about diabetes, we talk about glucose control, talk about blood pressure control, we talk about lipids control, we talk about macrovascular and microvascular disease. But what we often do not discuss, and I should say we doctors ourselves are also partially responsible for that, is regarding to what extent the depression contributes to the management of diabetes. As we'll all agree that diabetes is a lifelong disease. So obviously when a patient has got diabetes, this patient undergoes a state of depression. A large number of them, they do undergo the stage of depression. And the net result for it is poor compliance and a lot of other outcomes. Now, why this particular topic? Because we felt that many of our patients that when we, across which we come in a day-to-day consultation, often their compliance is not good. And when you delve a little more into the details, what we find out is that most of the time they're saying that, I'm not interested. Why? Because, I'm going to die because of diabetes. So what's the use in going for an intensive glucose control and following all the advices that you give? So this is the reason why we started this topic. And we did actually publish a paper last year. So I'll mention about the paper later on. But to start with, so basically, the slides are okay. So this is the agenda for today's discussion. So I'll talk initially about the depression, the definition and its clinical features. Then I'll go about the scoring system of depression, how you actually score a depression. What are the effects of depression in the management of diabetes? Then I'll talk about this study, the DEB-DAB study, which is basically a study on epidemiology on the contributory factors to depression. And lastly, I'll conclude with some suggestions on what is the way forward. Sorry, it's gone now again. Yep, okay. So what is the definition and what are the clinical features of depression? I think there's some problem with this. It's not. So basically, this is a definition of depression, a mood or an emotional state that is marked by the feelings of low self-esteem and guilt and reduced ability to enjoy life. And there are several severe symptoms that can affect how you feel, how you think, how you handle the daily activities such as sleeping, eating, and working. So this sort of a mood disturbance is something which can contribute to a sort of low self-esteem and can affect all these aspects of your life. And to diagnose depression, these symptoms have to be present for a minimum of 2 weeks. So that is official definition. I think there's something wrong with this. This slide is not working properly. Can you get it a little closer, please? Yeah. So this is the DSM-5 criteria of depression as mentioned in 2020. So basically the first 2 columns are the most important. That is depressed mood for most of the day, nearly every day, and markedly diminished interest or pleasure in all or almost all activities of most of the day, nearly every day. So these 2 are some of the constant features which have to be present if you want to make a diagnosis of depression. And some other factors like significant weight loss when not dieting or weight gain. So any sort of change in weight could be actually a manifestation of depression. Slowing down of thought and reduction of physical movements. The patient doesn't really feel like working out, making any movement at all, feeling absolutely exhausted and lethargic. Fatigue, feeling of worthlessness, diminished ability to think or concentrate, recurrent thoughts of death, recurrent suicidal ideation without a specific plan. So these are all features of depression that can be present. But to make a diagnosis, as you can see here, the individual must be experiencing 5 or more symptoms during the same 2-week period. And at least one of the symptoms should be one of the first 2 that I've talked about here. So this is how you diagnose a depression. Now, the points to note here is that depression can be mild, moderate, and severe, and how we classify patients as mild, moderate, and severe, I'm going to discuss later on. Some people can experience only a few symptoms, while others can experience many. And there is an entity known as a subsyndromal symptomatic depression, where the depression symptoms don't quite meet the criteria for a diagnosis of a major depressive disorder, but it includes patients who experience brief, recurring episodes of depressive symptoms. So as I mentioned, when you have to diagnose somebody with depression, you have to have the symptoms going on for at least 2 weeks. Now, this patient could be having, say, maybe an episode of one such symptomatic episode for lasting maybe 5 days. Maybe in a span of, say, 1 month, it gets 4 or 5 such episodes. So that will put this patient in this class known as a subsyndromal symptomatic depression. And this can have a major impact on function, the same risk factors as a major depression. So this is something which is often ignored, but this is something which we must not forget, because this is one of the big contributors to the evolution of a future depression. Now, these are the risk factors for depression. So if there's a personal or family history of depression, you run the risk of developing depression in the future. Major life changes, loss of job, any physical trauma, incapacitation, mental stress, physical illnesses, particularly several illnesses that come into the forefront, and one of them is diabetes. Other conditions which can contribute to depression or can lead to depression include cancer, a stroke leading to a physiological, to a residual neurological disability, Parkinsonism, coronary artery disease, particularly presence of a heart failure. This can be associated with depression. And last but not the least, any chronic painful state. So these are the specific causes which can lead to depression. Something is wrong here. So how do you assess the depression? So what are the scoring scales? So these are the 5 scales that are commonly used for diagnosing depression. For the sake of time, I will not take you through them, but it is there in front of you. So it's based on several point-based scoring system. And according to that, you can basically classify, depending upon the number of points, you can classify whether the patient has got mild depression, major depression, or severe depression. So basically, in our study, we included the Beck Depression Inventory and the PHQ-9, which is actually one of the very common, very popular ways of assessing depression scores. So what is the effect of depression in the management of diabetes? The answer is it's several-fold. Oh dear. Can we just get this thing corrected? It's just not working. So basically, effect of depression on diabetes, it leads to basically very poor self-care among diabetes patients. Associated with depression, it's a potential contributor to long-term poor glycemic control. It's a known fact. If the patient is depressed, the glycemic control is bound to be poor. And it impacts several stress pathways which can affect the HbA1c levels. And there is a doubling effect on the disability and the reduction of the quality of life with respect to physical, occupational, and psychological functioning. And last but not the least, depression can contribute to an increased mortality in patients with diabetes. So with that, so this was the DEB-DAB study which we published last year, 2021, in Diabetes Research and Clinical Practice. Can we please do something with this? I think I'll be better if I go and if you get the laptop over here, it will be easier for me to work on. This is just not working. आप कुछ कम नहीं कर रही जी. छोड़ी. So basically, this was the largest cross-sectional study from Asia. We recruited around 1,500 patients over a 1-year period. And ultimately, the full cohort size, which was included in the final analysis, was 1,371. And it was recruited from 8 hospitals and polyclinics in Kolkata and 1 district hospital in Raiganj, Uttar Pradesh, Uttar Dinajpur in West Bengal. Most of the patients were from Eastern India and Bangladesh. The inclusion criteria was diabetes more than 1 year with or without comorbidities. So we included all patients, those who met the inclusion criteria, but there were certain exclusion criteria, like patients with known previous depression or any other psychiatric illness, on treatment with antidepressants or any other psychiatric medicines, or any previous history of suicidal attempts. These patients were all excluded. And as I mentioned, that we used these 2 depression scoring systems, the PHQ-9 and the Beck Depression Scale. And basically, patients had the questionnaire translated in original one in English, was actually translated into Bengali and Hindi, the local vernacular languages. At the same time, we all know that depression has got a direct correlation with the socioeconomic status. So we also did a cross verification with another tool known as the revised Kusami and BG Prasad socioeconomic scales for 2016. So we merged these two things together and looked at the composite data. So this is what the questionnaire looks like. So basically, this was the total cohort size. So around 60% patients were male and another 40% patients were female. Now, around 4.1% patients had met the criteria of major depression and another 36% patients had minor depression. So altogether, around 40% patients of the entire cohort had some element of depression. And what is more staggering was that nearly 15% patients had a suicidal ideation. So we looked at the different contributory factors there. And this is something which we found it very interesting. The highest prevalence of depression was in the age group 18 to 40 years. So the young diabetic patients were at the highest risk of depression, though it contributed only 10% of the cohort. And this is basically from a paper that we published. So you can see here, the prevalence of depression was moderate in the middle age group, in the 41 to 60 years of age group, and least in the elderly group, which is more than 60. Obviously, this is also influenced by the individual population cohort of this different age groups. So obviously, that is something which had a role. But what our conclusion was that in general, the prevalence of depression reduced with the advancement of age after 40 years. Regarding sex, obviously, it was more common amongst the females. The females had nearly a 31% increased relative risk of depression. So there were 7 percentage points, and here the socioeconomic factors played a big role. Now, this is again actually a no-brainer. Lower the socioeconomic status, the higher was the prevalence of depression. And the difference rate between the upper and the lower socioeconomic class was highly significant. You can see here an odds ratio of 2.69. So nearly 2.7 times higher incidence of depression between the upper and the lower socioeconomic classes. And also there was a significant depression, nearly 2.25 between the upper and the lower middle class. So the higher your socioeconomic class was, the lesser the incidence of depression. The lower you went, the higher was the incidence of depression. Okay. Now, compliance of medications, what again we find out is again a busy slide. What I'll try to tell you is that there's a significant association between depression and poor compliance of medicines. This is actually what the methodology which we followed. So basically, we took the history, whether the patients stopped the medicines, and if they stopped, whether the symptoms got any better. So basically, we looked at their drug compliance, whether it was maintained during the travel. And a score of 1 was given if one answer was positive, and if this 3 and 0 when it was negative. A total score of more than 4 was deemed to label the non-compliance. So what we found out here was that in general, the depression cohort had a higher incidence of non-compliance. Now, the glycemic control, what we found out was that the depression patients had a significantly higher fasting plasma glucose levels and 2-hour PPG levels. Now, there was a catch here. The HbA1c data, it did not show any significant difference. And you can all find it very surprising to accept. But this, I should say, it was more of a technical flaw. Because of all the patients who came for the assessment, this was a cross-sectional study. So patients were recruited during the first presentation. What was the reality was that many of these patients, they did not have an HbA1c done. So that data was mixed out. So that is actually one of the lacunae of our study. But there was actually a numerical excess of depression in patients, even amongst the group who had the HbA1c done. If the HbA1c was more than 7%, there was a numerical excess of depression, but this was not statistically significant, simply because the number was a bit too low. Now, this is the other issue, that hypoglycemia was noted to be a common cause for depression. So basically, you can see here there is a 1.6 times increased risk of depression if the patient had recurrent hypoglycemia. And surprisingly, there was no significant association between insulin therapy and depression. This is again a common prevalent view that if you put somebody on insulin therapy, the patient is more likely to get depressed. But in our study, we did not find that. There was actually absolutely, as you can see here, the data is there in front of you. you can see here that there was absolutely no difference between insulin users and non-insulin users. The p-value was 0.102, which was absolutely no significance at all. We looked at the suicidal ideation, and patients who had repeated attacks of hypoglycemia, at least more than one episode per month, 22% experienced suicidal desire. Amongst patients who did not have hypoglycemia, that figure was only 12%. So recurrent hypoglycemia was one of the causative factors for suicidal desire. And patients with HbA1c less than 7, despite the hypoglycemia, they experienced lesser suicidal ideation than patients with HbA1c more than 7. So that was again another important take-home message. And there was no correlation with the body mass index, the fasting plasma glucose, or insulin usage. Insulin usage did not contribute to any hypoglycemic ideas. Depression definitely had an effect on the activities of daily living. So basically, this was a definitive association. And what we found out that on and whole, there were nearly 4.5 times increased impairment of the activities of daily living. That is the stand. Now, what do we mean by the activities of daily living? These are basically the simple stuff that a person does throughout the day, like, washing, brushing teeth, moving around, these sort of things. These are also affected very much if the patient has got depression. Regarding the hospitalization, there was no significant excess in hospitalization between the depressed and the non-depressed diabetes patients. In fact, patients with depression had a significant lower incidence of hospitalization. And the reason for that was probably because of the fact that these people that often did not report their complaints. And there was no correlation with depression and duration of diabetes, BMI, comorbidities, etc., etc. So to summarize, undiagnosed depression is present in a significant proportion of type 2 diabetes patients. As I showed it in 40% of our patients, young type 2 diabetes patients in the age group of 18 to 40 years had the highest prevalence of depression. Females on the whole had a 1.6 times increased risk of depression compared to males. Direct association was noted with the lower socioeconomic status. Poor socioeconomic status served as a hindrance to satisfactory glycemic control. And hypoglycemia was an independent variable contributing to depression in type 2 diabetes and increased suicidal ideation. Depression was positively associated with the poor medical compliance, and however, there was no correlation between insulin use, comorbidities, and the BMI. That did not show any, translate into any significant difference in the suicidal thoughts or in the incidence of depression. So what is the way forward? This is my simple summary for all Indian patients. This is what we need to do. We need to spend more time with the patient, which unfortunately is the biggest reason for not diagnosing depression. And you look out for symptoms of depression like non-compliance. A patient who is non-compliant due to any unjustified reason, you must look out for depression. That's my simple take-home message. All patients of diabetes, particularly those with recurrent hypoglycemia, poor glycemic control, should have an annual psychiatric assessment. This is something which we strongly recommend, that any patient who's having a long-standing poor hypoglycemia, long-standing poor glycemic control, recurrent hypoglycemia, a psychiatric assessment is must. A diagnosis of treatment of depression at an early stage can minimize the adverse outcomes of the poorly controlled type 2 diabetes. So with that, I end my presentation. Thank you very much. If there's any question, I'll like to take them. Yes.
Which medications you prefer for depression and diabetes?
All right.
With hypoglycemia and keeping in mind.
For diabetes?
Yes, sir.
Right. The current guideline says, if you look at the latest ADA-ASD guideline, which has just come up about a month ago, the commonest, nowadays they're advising you to start anybody on 3 classes of agents. One is after metformin, should go for the SGLT2 inhibitors or the DPP4 inhibitors or the GLP-1 receptor analogs. Now, in Indian practice, we tend to use sulfonylureas much more for the simple reason because they're cheap. But again, sulfonylureas, they do not confer any specific cardiovascular or renal benefits. So that is one issue. So if you really want to minimize hypoglycemia in such patients, my choice would be to start them on metformin, followed by a DPP4 inhibitor or an SGLT2 inhibitor to start with, because nowadays you've got lots of cheap SGLT2 inhibitors which are available in the market. Same thing with DPP4 inhibitors. A lot of cheap DPP4 inhibitors are available at the moment. So to start with, this I think should be the standard drugs. Sulfonylurea you can obviously use for somebody who is not that, I should say, proficient in the financial point. So that patients, these sort of patients, I mean, those patients you can start on sulfonylurea, but you should be very, very careful about use of sulfonylurea. People who are elderly, people who have got a history of renal impairment, any hepatocellular disorder, these patients, you should be a bit careful about starting them on sulfonylurea if you at all want to start them. So I hope that answers your question.
Thank you, sir. Any more questions from audience? Can we move on to the next session? So the next eminent speaker we have with us today is Dr. Sabyasachi Reza. I'll give a brief introduction. He doesn't require an introduction, but still I should. He's a consultant gastroenterologist, hepatologist at Peerless Hospital. He is a consultant gastroenterologist at Remedy Clinic, Lake Town at Kolkata. Presently, sir is a chairman of the Indian chapter of the Royal College of the Physicians of the Ireland, as well as the regional advisor. Sir is a senior most practitioner and examiner for ICRCPI examinations. And he's a president of Remedy Clinic Study Group. So I request Dr. Reza to begin his talk.
Good afternoon, everyone. Sorry about my voice. I'll try to keep it audible. My talk is based on a completely different spectrum and a wider area, because the subject I've chosen is something which is very much common in this society. The proton pump inhibitors are everywhere. For the last 20 years, not only that, most of the paid doctors are prescribing for one reason or another. Patients are going over the counter to buy for the so alleged indigestion. So my question is, can they resolve all dyspeptic problems? And if so, how? If they do all dyspeptic problems are resolved, then perhaps there will be no need for people like us. But story is not that easy. Let's think about the first question that we may arise. What is dyspepsia? The dyspepsia, the patients say it's indigestion, gas problem, or they take the gas kadawa, and the doctors say that is symptom complex of upper GI tract. So, and this dyspepsia, what's the background? It may be organic due to various conditions like that I mentioned here, and it's functional. Functional may have two subtypes, and postprandial distress syndrome, epigastric distress syndrome. And also the Rome criteria of Rome Foundation, which is a part of IBS workup, says that 4 combination of any 4 like postprandial fullness, early satiety, epigastric pain, epigastric burning, etc., will form this website. It's a rather complex symptoms bunch. Now, the other thing that is very often said, abdominal gas. The abdominal gas is in a very unclear situation. Patient comes and tells us that it's abdominal gas, the gas problem, but but we have to go into the details to see what is exactly the gas problem is all about. Different stories come from different symptoms. You have to ask question on symptoms basis to find out the answer. Now, what we see scientifically, the gases are formed in the stomach. What we call in stomach is mainly due to aerophagy. We swallow air while talking, eating, drinking, smoking, and chewing. And there often comes out the burp. And the large intestine, because of bacterial fermentation, carbohydrate, fibers, and other starches, etc. If you take too much of it and wrong food, it will cause more. So, but that's probably nothing to do, or not much to do, with the so-called dyspepsia or indigestion problem. Now, the organic causes. If you look at the endoscopic view, I can show you what are the problems we face with when you come up to the actual endoscopic situation. This is a hernia with esophagitis starting from the GERD, and there's a 4 grades of esophagitis on Los Angeles gradation, and the picture is probably not as clear as it should be, but anyway. And the next is if we don't treat these patients at all, it will end up with a stricture, which we really a very difficult situation to handle. And then we may also find mild gastritis or even a normal gastric mucosa. And we have a deep ulcer, and which is erosions. This patient is due to bile reflux in post-cholecystectomy patients. And this is a large ulcer caused by NSAID. Now, this normal, the so-called normal mucosa is not always normal, and the patients are taking PPI. Therefore, the patient has no obvious lesion, but if you look inside, the biopsy will probably show H. pylori infection. Now, what we have in Kitty, as we mentioned, the anti-secretory drugs, first of its kind was H2 receptor antagonist. The revolution was created by cimetidine, by discovery in 1977 by the then SKF, led by one Indian-born gastroenterologist, K.D. Burden, and it was a successful launch. Everybody thought this is the answer, not to be, but there were some problems, and they followed by more refined stuff like ranitidine, famotidine, roxetidine, and then simultaneously proton pump inhibitors came into being in 1983, followed by this graph that's in 1983, omeprazole, lansoprazole, rabeprazole, esomeprazole, pantoprazole, and then dextromethorphan. So in the 2008 or 9, after that, I don't think there are many which has come about and which come to the notice of the clinicians. Now, this is a proton pump. There's an acid secreting mechanism in the parietal cells of the stomach, where there are so many mechanisms that has shown up, which I will just see on the left side, the H2 receptor antagonist, and the medication we're talking about is PPI, which blocks the final pathway, HTPase. And the next, the features of PPI are effectively blocking the gastric acid by irreversibly binding and inhibiting the hydrogen potassium ATPase pump. And it also has anti-ulcer agents that are both anti-secretory as well as mucosal protective action. As far as the mucosal protection action is not very easy, I'm not sure how much it can do. Certainly at some, but as people think, it also does both in the same manner. We have a lot of doubt. Otherwise, patients having PPI wouldn't have erosions or ulcers in some cases. Now, PPI cannot evade all gastric acid pumps by oral dosing. Only at a given time within 90 minutes, 70% pump works. So it's not all blocked, some left depending on the dose and the timing. Now, what happens, the long-term use, that's the real problem we have faced with. If we look properly, there's abandoned use, indiscriminate use can create a problem. And just going through very quickly, hypergastinemia, causing rebound hyperacidity, and then pneumonia due to acid reflux, clostridium difficile causing diarrhea, fractures because of calcium deficiency, the hypomagnesemia, vitamin B12 deficiency, and the rare problems like intestinal nephritis, dementia, and cutaneous lupus erythematosus, and some interactions. The following paper that I'm citing here, the long-term use of proton pump inhibitors versus risk factors for various adverse manifestations, which was published in 2021, which is the gist is the long-term acid suppression by PPI can also lead to enteric, respiratory, urinary tract infection, hyperchlorhydria. By chronic PPI may use hypergastremia, which ultimately mediates to gastric polyp, gastric carcinoid, even gastric cancer. It also says PPI and with antiplatelet drugs like clopidogrel can make it to major adverse reaction. Now, the next slide paper, which is also published in 17 and by a group of researchers, has a similar conclusion, and they have a following conclusion, which is highlighted: superior efficacy and overall safety factor, but is gross overuse and inappropriate use, and leads to half the patients do not have a clear indication. Adverse effects, which is definitely coming from receiving long-term therapy, and we, the physicians and paramedics and pharmacists, should be ensuring PPI is used associated with appropriate indication, utilizing lowest effective dose for the shortest possible period. And then if we have a problem, proton pump inhibitors, and which is thought the panacea of treatment, what do we have on a kitty? And then what options with or without PPI? Mucosal protectants, prokinetics, sodium alginate, and antacids. The antacid used to be the mainstay before the advent of cimetidine. We all know the mixtures, which is not regarded as antacids, which is actually an alkali, which is the opposite of acid, which should be used naturally. And sodium alginate has been in vogue for about 60 years, and sodium alginate has been used very successfully before the advent of PPI, H2RA. Prokinetic is very useful, as you know, like the good old metoclopramide, domperidone, and the many others that are used. So that has got a very useful role in managing peptic ulcer disease and dyspepsia. As a prokinetic drug is definitely helpful. And mucosal protectants is the ones we are talking about now. Now, before we talk about mucosal protectant, what we have to know, what are the barriers, mucosal barriers? There are three barriers in the gastric barriers. One is compact epithelial cells. Next is the special mucosal covering derived from the mucus secreting surface of the epithelial cells and the fibular cells. And the third, bicarbonate ions. So these are the barriers. So factors damaging and that can causing damage of the barrier are bacterial infection, H. pylori, alcohol, smoking, reflux of bile and pancreatic secretions, stress from illness and injuries, and drugs like corticosteroid, NSAIDs, aspirin, spironolactone, and ACE inhibitors. Now, what do we have in our kitty? The lists are prostaglandin analogs, sucralfate, ribamipide. It's difficult to pronounce, so I might use the generic trade name, which is the only drug in the market, the Rebagen, and colloidal bismuth subcitrate, CVS. Prostaglandin analogs are not used for the last 30 years. Misoprostol and prostils has been in vogue in the 80s, but they have quite a difficult problem with the maximum effective dose and side effects, which are profuse diarrhea. So it has been abandoned, particularly after the advent of all these wonderful drugs that followed these prostaglandin analogs. Next is the sucralfate, the drug which is very well known and widely used in India and elsewhere. And what are the facts? Is what happens? The polymer of sucrose and aluminum hydroxide forms a protective coating on the mucosal lining, particularly in ulcerative areas. In the presence of acid, mark the point acid, it becomes a gel and adheres to the epithelial cells and ulcer craters. Minimally absorbed, all that is very good. The question is mild, severe, adverse reaction like bloating and constipation. But the question is it worthwhile using it in combination of PPI. A lot of people are using it. And my question is, if this medication works in an acid media, and when you put PPI to the person, another person whose pH is over 6 by giving PPI, and can it work? The suggestion is you work with a space of give the patient with 1 hour in between them, so that the effective one doesn't affect the others. But it's not really not very easy to convince myself, but I tend to avoid it nowadays. And also another problem is available in liquid form, so it's difficult for the patient to carry around. Now we have to think about the others. I'll be talking mainly on the other two drugs, ribamipide. I will say Rivaroxaban from now on, and then we'll talk about H. pylori and bismuth. Ribamipide, salient informations is a gastroprotective drug, was developed in Japan for treatment of peptic ulcer disease in around 2000, and it is available in India about 2004. And I think this is the only product, the only company is producing is one, which is named as Rivaroxaban. So far, I do not know about any other company. There are multiple mechanisms of action, increases the prostaglandin E2, mucus and bicarbonate secretion, and helps the replacement of lost tissue by increasing the expression of epidermal growth factor, EGF and EGF receptors. And EGF causes angiogenesis, increased production of granulation tissue, and epithelialization of the ulcer healing. Adequate evidence that this in sufficient dosage of 100 milligrams 3 times a day, it is very much useful in aphthous ulcer, GERD, post-Band-Aid ulcers, various gastropathies, and I'll come to that in the next few slides. Oh, sorry, side effects. There are only a few side effects. Constipation, bloating, diarrhea, nausea, vomiting, hyperacidity, and rash less than 10%. I didn't think there are many serious side effects. Next is I'm citing this example of this study, which was done in 2014, and this is aspirin, clopidogrel, and ribamimide. And this says the study says that ribamimide is useful in primary prevention of gastric injury induced by LDA and without aspirin or with aspirin, plus clopidogrel at all situations with or without aspirin has been very usefully protecting the gastric mucosa. Next is the effect on the reflux disease. The patient with GERD and non-erosive gastric reflux disease. This particular study in 2019 took 139 patients with GERD, including 50 patients with GERD, and 139 of GERD and 50 of non-erosive gastric reflux disease. And PPI plus ribamimide found one group, that is a ribamimide group, and the other one is PPI plus placebo. The group with ribamimide has significantly improved the condition of the patient, and there is controlling the reflux disease. So the next one is the non-steroidal anti-inflammatory drugs induce gastropathy. And this 15 RCT summary of 15 RCTs, including 965 individuals, and this inference is effective and safe for defending against NSAI-induced gastroduodenal and lower GI injuries. That is, as you know, the NSAIDs not only affects the upper GI, it also affects the small intestine and even large intestine. So the ulcer can be there without that cannot be touched by PPI. So this might be additional help. And in H. pylori, it's a long-term ramified treatment. It improves histologic gastritis as well as increased gastrin level in H. pylori gastritis. So, and in a combination of triple therapy or quadruple therapy, it also has fared better in this article. So in functional dyspepsia, it also fared better. And this is also functional. I'll go for this post-varicose ulcer situation, which is very interesting, which is probably could make a lot of difference if it's proved to be actually by measure other studies. And this says post-EVL ulcers, and it shows it effective in decreasing the post-banding complication and reducing size of the ulcer, as well as the number of ulcers, with no significant effect on the post-banding ulcer formation. It can be routinely used to say, they're suggesting for setting the post-EVL as good alternative to pantoprazole and also sucralfate. This is comparison between the verapamide, pantoprazole, and sucralfate. So as you can see, they normally, we all give PPI following EVL, and some people also give sucralfate. But if you give this molecule, it might be much more useful. Now, my own observation, as I said before, I have been using this medication for several years, but I've never kept a record. Over the last 8 weeks, I thought I just keep some auditing, and I just did this. I have used in 27 patients so far in the last 8 weeks with indication of GERD, erosions, bile reflux, post-cholecystectomy, and normal bile reflux. The patients are, most of them are symptomatic. And I've used in one patient of H. pylori eradication. And I've been asking questionnaire about the effect and side effect after 2 weeks in person with the come for follow-up or over the phone. And the initial response is very encouraging that certainly nobody has complained of any tolerance and adverse event situation, but many of them are saying they're beneficial. It's too early to comment on from my side. But on the whole, I'm quite impressed about this medication. And I think there's an underused drug, which has a lot of potential in the community. So next is H. pylori. No discussion on dyspepsia or PUD is complete without talking about H. pylori. And this is H. pylori, a flagellated double membrane bacteria, gram-negative bacteria. And it inhabits in submucosa of the stomach and duodenum. It produces enzymes, particularly urease, and is a low-grade inflammation formation. The survival in H. pylori in acid stomach is dependent on the urease, which generates ammonia, leading to alkaline environment around the organism. Now, the other factor is the route of transmission is fecal-oral, oral, or via endoscopes. It may be contagious, as you may find that there are several members of the same family have the same disease, and some of them may have no symptoms. Poor hygiene is one of the reasons related to more socio-economic than racial factors. Infections may be acquired anytime, more in the childhood and in increasing age, and it's got a carcinogen 1 classification by WHO, and it's got 2 genotypes, CAC-A and BAC-A. This is the worldwide prevalence in 2018. India scoring 35 to 54%, that's 9%. Now, these two gentlemen are very famous, and I have not seen any or many Nobel laureate in gastroenterology or medical science. And the left side is Barry Marshall, and there's Christopher Warren. The Barry Marshall, I cannot help telling you the very short story of the long version, that this Barry Marshall was a senior registrar in Perth, Australia, and trying to write some papers and given some loads of notes by his consultant and said, look at them. And he looked at them and found that was 1978, 79, when the cimetidine one is in market. Everybody is having cimetidine for few months after an ulcer treatment, stops them, comes back with another ulcer and bleeding, having another course of cimetidine, and comes back in. So it is in 1 year, perhaps 2 or 3 times, the person comes with the same problem and treated with short course of cimetidine. So he asked this question to his professor, and he said to go to Christopher Warren in lab. He has found some bug in the stomach, and he is actually in the postmortem. So they started working together, but they could not fulfill the answer because they could not grow the organism in the laboratory. So it happened in 1982 Easter. There was a long holiday. They left this in the incubator, and 5 days later, when they came, they found that there is a growth after 5 days. This shows it takes more than 3 days, unlike the other organisms, to grow. So then studies started from there. He tried to prove them and explained to the physicians. They did not believe. So he drank a solution of H. pylori and got himself an ulcer and was treated by an antibiotic and got cured. Then story went on, lots of developments went on. And then next thing is, I cannot help showing this picture because I've managed to find this gentleman in New Delhi in 2008. And because they also have that Nobel Prize in 2005 after 25 years, both of them. And this article was written in 1990 in World Congress. All the directions and the treatment was given at that time, and most of them are being followed now. Now, clinical presentation may be asymptomatic, maybe chronic dyspepsia, maybe ulcers, and maybe, sorry. Okay, sorry, they're just kind of show that the complications is going too fast. Complications like adenocarcinoma and lymphoma, particularly multiple lymphoma. A diagnosis, non-invasive and invasive. Non-invasive, the gold standard said to be carbon-urea breath test, but it is, although it's a gold standard, it's difficult to find in particularly in India and even elsewhere, and it's expensive, and so we cannot go for it. Others are not quite in vogue, and PCR is not very commonly used and very expensive as well. So what we do is most commonly done here is endoscopy. During endoscopy, take a biopsy and do urease test. You can also do histology and culture, but that's a very bit long shot. But rapid urease test is the most commonly done here. Now it's stuck. Now I found it. What is urease test? Simply, urea is acted upon by urease enzyme and break down the carbon dioxide, water, and ammonia. Ammonia increases the pH to high level to over 6. It's the 6.8, and then the color of the urease test changes. The next slide shows how it is done. The photograph was taken during COVID period. That's why you see everybody undercover. So you take biopsy from the antrum, you put it in the slide, and the color changes to magenta if it's positive. Treatment. Bismuth compound is the most important thing is bismuth. It's been available for more than 200 years. Inhibits in urease by blocking the active site of the enzyme. Interferes in addition of enzyme to the gastric epithelium, as well as inhibiting the organism's urease phospholipidase and proteolytic enzyme. Partially involved prostaglandin mechanism. Protects the gastric mucosa and aid in ulcer healing. For the dyspepsia as well as H. pylori and peptic ulcer disease, 120 milligram, 2 tablets twice daily. There has been recommendations that containing the quadruple treatment with CBS as considered to be high increased efficacy and recommended for the first line treatment in the areas of high clarithromycin resistance. achieve superior medical eradication with safety and tolerability comparable to those obtained with the triple therapy. And there's one Indian paper led by Dr. Thagarajan from Chennai, and they have taken from the data from 5 different areas of this regions of this country, and they come out with this conclusion that the rates of resistance higher in southern India and then in northern India, it emerges as a reliable quantitative antibiotic susceptibility test, a change of antibiotic policy to provide the scope of rotation antibiotics and treatment of H. pylori in India and in the public health emergency. Here with all these indiscriminate use of the antibiotic, the resistance grows very rapidly. Therefore, every year or 2 years, you have to change the antibiotic to come up with the proper answer. Now, the eradication, we know from the beginning, only triple therapy and quadruple therapy has been recommended. I prefer quadruple, and sequential therapy are used by some people. Choice of antibiotics like proton pump inhibitors, nitroivinizole, not much used these days, and bismuth. Probiotic rifabutin vaccine is not available yet. And the ISG task force guidelines in 2018 approved the point that was made earlier because it's transmissible disease. What they said, which was a really question before, the H. pylori eradication does not cause GERD. There was a myth that saying that treating H. pylori will cause GERD, which is not true. Testing and treatment of H. pylori is indicated patients for long-term NSAIDs. That also their recommendation was. Now, in my preference would be quadruple therapy. And now I keep thinking about they put that year and start thinking about particular antibiotics. And now I realize last year I was using more of doxycycline, but now I think doxycycline has a tolerance problem, particularly after the COVID, over a lot of use during the COVID period. The resistance has also increased significantly. Therefore, levofloxacin or cephalosporin group is going to be my preference for now. Proton pump inhibitors, anyone will do. CVS is certainly a good choice. I mentioned probiotics should be added, and ribamipide is also should be in the list, which I already started thinking about. And nitrometazole not used. I do not use H. pylori kit because it's all given in one fixed dose, and you cannot change it. You cannot alter the dosage. You cannot stop it if there is a side effect to one of the 3 kits. So you have to, I always prefer to treat them with different drugs giving separately. Now, in my observation, the last 12 months, I have found with this quadruple therapy, there's about 20 to 25% of patients having positive results. Now, the other things that we should be talking about is alginate. As I said, it's been around for several years, since 4 or 5 decades. And what is called there's an acid pocket, as you can see on the right side, by the pepsin, bile, and food. And what alginate does, it displaces the acid pocket, traps pepsin and bile, impedes the reflux of the gastric contents, and protects the contents of the stomach to go up to the esophagus, causing reflux disease. So it's very useful. It should be taken 10 meals, just 10 minutes after the meal, and we should not take any food or drink for a half an hour so that it prevents washing away the medicines. And finally, this shows the list. First and foremost, a lifestyle modification, acid suppression, then prokinetics for LOS support, and then alginates. Now, the take-home message is that lifestyle modification and maintenance of the lifestyle modification is the cornerstone of successful therapy. Careful clinical evaluation of the patients prior to appropriate screening and definitive investigation is mandatory. PPI revolutionized the management of acid-related disorders with superior efficacy and overall safety profile. However, patients receiving long-term therapy usually results in adverse effects. To ensure appropriate use of PPI with the lowest effective dose for the shortest duration possible. And HPRA is a remarkable discovery, has made an enormous change in treating PUD. Global transmission of disease, more prevalent in developing countries. During endoscopy, if no contraindication for biopsy, the rapid urease test is recommended as a convenient, reliable, and inexpensive first-line diagnostic test. And quadruple medic eradication regime with PPI, appropriate antibiotics, mucosal protection with CBS and or mivapamide are recommended. And rivapamide is a unique gastroprotective drug with multiple mechanisms of action and no major side effects. And safety and effectivity should be used more often alone and in combination with PPI and H2RA. And bismuth is safe, effective, cytoprotective agent, no obvious side effects. There's one side effect which I didn't mention, the black stool, which you mentioned to every patient for whatever reason you give bismuth, they should not be thinking as melena. Quadruple treatment regime containing bismuth have increased efficacy, recommended first-line treatment, achieve superior eradication with efficacy and tolerability comparable to those obtained in the standard triple therapy. And so I strongly recommend these both, particularly rivapamide, very underused mucosal protectant, and more often in alone or in combination with anti-secretory drugs. And actually, this medication is suitable for not only physicians and gastroenterologists, but others like dermatologists, orthopedic surgeons, cardiologists, and so on, so that the mucosal protection is required not only for peptic ulcer disease, but also for preventing drug-induced problems. Thank you for your kind attention.
Thank you, sir. Any questions? Any questions from your side? Sir, I have one question.
Yes.
Supposing the patient requires NSAID and still the patient has an evidence of gastritis or peptic ulcer, what therapeutic options are we left with?
Patient has a peptic ulcer, needs NSAIDs. Sorry, say it again. The question is not very clear to me.
Suppose the patient requires NSAIDs,
Yes.
and he has got a gastritis documented or a peptic ulcer, but he cannot discontinue it. What are the therapeutic options in such cases?
Therapeutic option, first of all, is to treat the peptic ulcer disease and avoid NSAID if at all possible, or then give alongside the protective agents. That now that all the doctors who give NSAIDs, including me perhaps, who gives that NSAIDs where the related problem will be solved by the PPI, which is not the case more often than not. Therefore, addition of this, one of these two medications, particularly Revagen, will definitely help.
Thank you, sir. Any questions?
Thank you very much for
Thank
your
you, sir.
participation hearing.
Begin my talk.
Yes, of course. You announce yourself.
You have to ring your own bells. Akshay? Good evening, friends, and thank you all the senior members of the RCPI Indian chapters, all the audience here. And my talk is the last. I can understand we all are fatigued. I really am thankful and indebted for the entire fraternity for giving me this opportunity to deliver talk. And special thanks to all the members who have come all the way from the different distant places. You might have seen my topic of choice is the forgotten art, clinical examination in the lines of MRCP examination. I'm not here to teach you or train you or inform you or update you how to examine the patient. This is not the forum. Deliberately, I've chosen this topic so as to bring to your knowledge that here, when we are trying to talk about the clinical examination, I do mean to say that everything has to be answered at the bedside. The real practice of internal medicine lies at the bedside, where all the questions has to be answered. Listen to the patient gives you the diagnosis. It's unfortunate to see nowadays in the technological era, we as a physician, we are forgetting the art of medicine. We are more imbibed into the science of medicine. The more and more science and the less and less art we are losing. The robots are taking place of the surgeons. The artificial intelligence are taking place of physician, but still in an era where we are lacking. It's very sad and unfortunate to see that when I was teaching students final year, I come across various textbooks because the knowledge isn't derived never from one single source, it is often derived from multiple sources. It is not to my surprise when I read a lot many Indian authors, the first line they write in the preface, unlike the Western countries, India is a developing nation, India is a poor nation, the patient cannot afford the investigation, so you need to be very, very good in clinical methods. But honestly speaking, when I'm here, we have found that the clinical method is at the verge of end. It's only for the examination's sake. Then where does this question arises when I'm trying to talk about the clinical examination from the MRCP point of view, friends? As we all are aware, in our country, we don't have an audit system, but in Western countries, in Europe, in Ireland, and UK, supposing you are examining a patient with a headache and tomorrow after 10 months, the patient comes with space occupying lesions and you miss it out in your findings. The audit will ask you, show your papers of clinical examination. Please understand, here you can ask your patient to go and get a CT scan done. Unlike in Western countries, the radiologist will say, provide me the history and the examination of the physician. Was it really necessary for this patient to send? So what I mean to say that please do not be under this impression the clinical examination has no value. No, it's very sad to say the clinical examination, the good history, a communication skill is very, very, very important in those parts. And that is what the MRCP examination teaches you. As we acquire more and more qualification, more and more specialization, by the time when we step out into the practical field, we forget how to hold a conversation. We don't know how to speak to a patient. You don't know Alzheimer's disease? What nonsense, I have only 5 minutes. Please understand, we are getting more and more rude because we are more concerned with the science rather than the art of medicine. This is where the point, friends, I just want to talk because my senior doctors have already spoken at wealth. Details of MRCP examination, part 1 theory and all those things. I'll be trying to touch upon certain aspects to make you a good clinician and how the MRCP Ireland examination helps you to achieve those targets. So I'm just trying to come to the point. If a physician is not good enough in talking, you may lose your registration. Please understand, during the MRCP examination, when we see a candidate performing his examination, we see his approach, the way of talking. Is he attentive to the patient? So these are the small things which is very important, for the reason we believe that tomorrow, once when you acquire this international benchmark MRCPI before your name and nominal, they expect that you have a full license to practice in UK and Ireland and further pursue your higher studies. But unfortunately, if you don't know how to hold a conversation, you don't know how to examine, you may be good enough in telling the CSF pressure, but you don't know how to feel the pulse. You don't know how to feel what are the double peaks. There where the problem lies, because everything has to be answered. And there is the point where I often talk what the MRCPI clinical examination teaches you. Howsoever you may be good in your knowledge, but it teaches you the way of examining. Please understand, I being an examiner, when the student comes and touches and the way he approaches, the way he walks, the way he looks at the patient and the way he communicates to the patient makes a sense that yes, he is a physician who is ready for the battlefield, real practical. See, his theories have been assessed in part 1 and part 2 examination. In the clinical, the way he moves his hand, the way he holds the stetho, the way he holds the hammer, the way he touches the patient, and the way he brings the confidence. That is the way we try to see that. You may be having a very good knowledge, but where the things are lacking, that is what the MRCP clinical examination teaches you. So today, as we are running short of time and my senior doctors have to leave for the airport, I'll try to make my talk very simple. And to all those students who are desirous for taking up this examination, for them, I'm telling you, this is a very good opportunity to become a good clinician within you. So, as you all know, that the MRCP part 2 clinical examination usually consists of, basically UK and Ireland is more or less the same. The format is a bit different. Here we have 2 long cases. Please understand, which is each long case consists of 25 minutes each and 5 short cases and 1 communication skills. Very important. Please understand, right now in our part of the country, there are the workshops conducted for the doctors about the communication skills. This was already there. And they have found that howsoever you may be good, if you don't know how to hold a conversation, you're out. You're not fit enough. Your knowledge has increased far more than your wisdom. No. Patient is here to listen. They want you to be listened. So the communication skill is very important. So today I'll be giving you a brief idea that what exact the examination takes place. Definitely you may argue, sir, in 25 minutes, how will it going to assess? In this 25 minutes, please understand what are the important merits on basis of which we try to assess the candidate. It teaches you, very important point, a clinical communication skill. First and foremost, the clinical communication skill. Whether the patient comes from any cultural, ethical background or something, how you begin your conversation to the patient. The first appearance is the last. The barrier is broken, the patient is very easy. See, the examiner says, yes, you're very at ease. You're at the level of the patient. You sit by the side, you're attentive. Yes, doctor is attentive. The communication skill, managing the relationship with the patient. The art of physical examination, how you examine the patient, that carries independent mark. And the next is how you identify the physical sign, that carries independent mark. Then how you draw your differential diagnosis, that carries independent mark. And your own clinical judgment. Please understand your own clinical judgment. There are the cases where you may differ from the examiner. It does not matter. Here in our part, majority times you have to agree what the examiner thinks. It is not so. You may differ. What we see during the examination or during the training of the MRCPI clinical examination, how the student takes a history. There might be the point where I, being an examiner, might have missed, or the patient might not have told me the details, but the student is trying to tell because he's more open. Please understand. So the history, the approach, the communication skill, managing the relationship with the patient, physical examination, identifying physical sign, drawing a good differential diagnosis. And thereafter the differential diagnosis, you have to plan a management. And above all, the patient safety, how much you are concerned about the safety of the patient. Because your theoretical knowledge is already examiners are not much bothered how deep you know. They're concerned whether you fulfill certain criteria. So this is the way we try to assess. So there'll be 2 long cases and 5 short cases, out of which one will be the communication skill, friends. So the forgotten art is here. In the short cases, usually we have a communication and ethics station. Either you have a cardiorespiratory, endocrine, neurology, locomotor, or abdominal examination. See, please understand, for the short cases, there will be 10 minutes each for them. And in that 10 minutes, you'll be given a 5 minutes for a discussion. So the examiner tries to know. Even if you differ in the opinion, doesn't make any difference. That is your approach, which tries to help you out. So the clinical part does what often has been, we think that in the Western countries, it is not so. It is not so. It teaches you in a very good way how to become a good clinician. So this is what we teach in the clinical. And I'm very happy and I'm really blessed that I still remember that I had done the workshop, which was conducted by Dr. Ray sir long back before my MRCP examination. And it was a wonderful experience. Please understand that one needs to go to those workshops and see how the things have been conducted. So in short cases, remember, after this, understand how we give the marks to our patients in this examination. Before that, I just want to tell you something. Talking about the sexuality, talking about or disclosing the sexually transmitted diseases, breaking a bad news, certain ethics that you want to complain that your colleagues are not doing proper work, ethical stations. There are the stations where it is a conflicting. You come across a patient who is dying and there is a organ donation card and the patient is on ventilator. The patient is branded and the relative comes to you and tells you, I don't want my father or my mother to give the organ, but just before the death, obtaining a consent. All these things, these are the real challenging situation. Please, friend, mark my word. Even in the real case, these are the points of litigation where howsoever you may be good enough, just because you have not communicated in a proper way. See, so there are, what are the passing marks? How we try to give the passing on this? Please understand that when we say a individual or a candidate will fail, if they fail in both the long cases, please understand, if they fail in both the long cases, if they fail in more than 2 short cases, they did not reach the pass mark for the above skill in any of the categories. Please understand, any of the categories. Now, when I speak about the categories can be a clinical communication skill. You may be good in physical examination. You may be good in identifying physical signs. You may be good about. Even if you're bad in differential diagnosis as well, you're bad in identifying physical signs, you may be good enough, you will be declared failed. As far as the passing is concerned, we do it on the basis of the equation marks. Depends upon how tough the exam was, number of candidates who have appeared, and they do an equating system. So at times it may close to 60%, at time it may get close to 70% as well. Supposing you might have scored 68% and you may be very happy and the result will come, all those who have got less than 70% were declared fail. And even Dr. Dinesh Jain sir has given a very good citation in the beginning, the books to be referred, how to prepare for these exams and all. So we assess all those things in part 1 and part 2. For the clinical, we see whether an individual candidate without the aid of any sophisticated instrument is able to come to a proper conclusion, that to meeting the satisfying criteria by the patient and the environment through the communication skill, patient's management, and so on. And one thing is for sure, friends, that you'll immensely benefit with it. So this is how we try to do a clinical examination on these principles of MRCPI examination. So with this, I just want to short curtail. I'm not here to go for individual examination because that is beyond the scope of this talk. So with this, I just want to curtail my talk because I have to deliver other talk as well because we are running out of beyond 23rd of this month, October. This MedPrep is an independent body. And usually majority of the doctors have already completed their MRCP examinations. Many are located abroad. Eminent speakers are there. Here we train our students, our candidates, to prepare for the MRCP UK as well as MRCP Ireland examination. As you can clearly see, immunology, and so on and so forth. This is huge. Now, what is our usual approach on MedPrep courses? The first and foremost is what Dr. Dinesh Jain sir has said, what should be the teaching pattern? I do agree with that point. Here we give you a case scenarios, not one case scenarios. They are the multiple case scenarios, which are based on the previous examination themes. It's not on my whims and fancies. Please understand. Point of view, but we have to tell him that as per UK guidelines, see, there are two guidelines which governs the entire medical fraternity. Few people follow the American and few people follow the European. For all practical purpose here for the MRCP examination, as this is a European one more, we follow UK, nice guidelines more. There are very minor variations. Only that, after the particular question, we tell the student that similar question, if twisted, can be asked in such a way. Please understand, during the clinical examination, when you appear for this MRCP examination, you are left with only 1.4 minutes to answer a lengthy question. So your speed of English should be quite good. Your ability vast majority of topics have been covered. As far as the textbooks are concerned for this, you may read any good amount of textbooks. You may rely, we never recommend one single textbook, but we teach in that pattern. Second, it is a live interaction. So you can contact. Other than that, after the session, you have a privilege to contact the respective teacher for your doubts. And we are doing it Ireland. Not only that, you can pursue your higher specialist training in these countries as well. So only a very minor differences are there, but by examinations, which will be starting on 23rd of this month. And I request and encourage you all to help your forthcoming doctors, future generation of doctors to enroll for this. Irrespective, knowledge never goes in vain. As far as the knowledge is concerned, the more is the less, I can say. So we as a doctor are even perpetual student. So I often call my student of different ages, so we even learn equally. So you can invite, there's nothing wrong in that. We get more knowledge, but one thing is for sure, it will be a focused from the examination point of view. The questions will be covered. The answers will be discussed as per the guidelines. And thereafter we'll have the tutorials. Many a times I being an examiner, when I teach my student, even my own biases have been broken. I come to the conclusion, no, this is right. This is right. This is wrong. The guideline may be wrong because I'm practicing last 20 years. How this can be possible? Then I have to peep into the guideline to see, no, I was wrong. And I remember one very important word a senior professor, Dr. Harrison, textbook of medicine, he has used one word. I would like to quote, the gray-haired experts are often wrong, but they are rarely in doubt. The gray-haired experts are often wrong, but they're rarely in doubt. So the same goes with all of us because, and this is where it breaks our own bias and nothing is, static. It's always in a state of a dynamic. So this med prep courses, I request and recommend all the students do join from the knowledge point of view, take a glimpse. At least that will build a confidence for you people to take up the examinations so that you can equip yourself in a better way, So for any queries, we have given you with our numbers, our officers are there. We are there to help you out. And again, to conclude, I thank every eminent speakers for taking such a valuable time. I know they are stalwarts in their own field. They're very busy doctors. They've taken toil to prepare their own slides. I can understand. Thank you everyone for this beautiful get together and CME. Any questions from your end? Most welcome. I would like to conclude my talk and thank you RCPI Indian chapter for giving me this opportunity to deliver this short talk. So I want Dr. Sujoy sir to conclude this session. Thank you very much.
Thank you, Avilash. It's really sort of a task to really draw any session to a close. We all know that all good things have to come to an end at some point of time. And we are really thankful to Avilash for organizing such a wonderful meeting here today. It was really worth the trouble that we took for coming all the way from Calcutta and Delhi. And Dr. Chadda is here, who obviously did not have to make that much of a trouble to come here. But we had some fantastic sessions, which was also eye-openers for us, forgetting about the MRCP examination, which is always there. In fact, the reason why we have this common platform, which started way back in 2005, with the first MRCP examinations in Calcutta. And to be very honest, some of the senior people like us, like me, Dr. Ray, we have done our membership examinations in UK and Ireland. And I can tell you how difficult it was at that time, because at least here you have got the med prep course. When I took the examinations, there was absolutely nothing. We had some dedicated courses in UK when I was working there, but courses specific for, say, a neurology course, a course for cardiovascular medicine like that. Nothing such as an all-pervading course like what med prep is doing here. And I still remember when I went for my MRCP clinicals in that day, and let me be very honest here, when you're taking the exam in UK or Ireland, there is actually a bit of a racial discrimination. I should not be saying that, but it was there. On the day when I took the clinical examination, there were 10 candidates. And of them, I should say around 5 or 6 were Asians, Indians, Pakistanis, Bangladeshis, one guy from Africa. I was the only non-white candidate to pass on that day. Out of the 10 candidates, 3 candidates passed in the clinicals, and I was the only non-white candidate. So obviously, I must tell you, those of you who are taking the exam here in India, for them, it's absolutely a different ball game. For the simple reason, because you're working in a family, you're giving the exam in your own country. It's not a foreign land with hostile people. So that's an important, very important issue when we're talking about an examination. And actually, I'm telling you, from the experience of the exam, I did not pass MRCP in the first go. Let me be very honest here. I passed the part 1 in the first go, but in the part 2 clinicals, I remember, and I'm sorry to take up this time, we had to travel from UK to Ireland. And at that time, there was this very funny rule that if you had a long-standing UK visa, I was working in UK at the time. If you had a long-standing UK visa, you did not need an Irish visa. So I went everywhere. Whenever I went for the clinicals, I used to, go there a couple of days earlier. So we were traveling from one small port by the sea across the Irish Sea to land up in Dublin. When I entered Dublin at the seaport, there was an immigration officer waiting there. Can I have a look at your passports, gentlemen? I said, yes. You don't have an Irish visa. So no, I don't, because I've got a long-standing UK visa. And he said, well, sorry, gentlemen, I cannot allow you to enter. Sorry, I'm appearing for an exam. Nothing doing. he put a stamp on that and put a cross mark, which is a symbol of deportation. So I was deported from Ireland back to UK. I had to rush back from where I was working in UK to London, to Grosvenor Square, to get a visa, catch a flight, and take the flight to Ireland the next day. So I arrived in the late hours of the night. Next morning, I was rushing for the exam. So obviously, I didn't pass that time. There's no harm in admitting that. Next time when I went, I passed. So this is the sort of problems that you face when you're taking the exam abroad. And this is the problems exactly what you don't face when you're working in India. It's just like going for an exam, just like I've traveled from Calcutta to Bombay today. In the similar way, those of you who want to take that exam, for example, in any part of India, say maybe Delhi, maybe Bombay, maybe Chennai, it's just one single flight. You can travel the day before. You can familiarize now with the Google. In our days, the Google mapping was not there. So we remember it was such a tremendous trouble to find out the place, because at that time, when we took the exam, the part 2 clinicals and the part 2 theory, but they were held on the part 2 vivas, they were held on the same day. So initially you had to appear for a separate viva. And once you cleared that viva, theory plus viva together, if you passed it, only then you're eligible for the clinicals. At maybe 1 o'clock, the list would come up in the Kildare Street in the Royal College office. And then you'd know where you're supposed to go, and you had only 1 hour time to reach that particular destination in an area of Dublin, which you didn't know. So you have to depend entirely on the taxi driver if he could take you to the right place. When you're taking this exam in India, you do not have such a problem, honestly speaking. And we, on behalf of the Indian chapter of the Royal College of Physicians of Ireland, we have been doing a series of meetings for the last few years. Has brought everything to a halt, but we are planning to restart it. And if we get a support from all of you, all the younger brains like Abhilash and many others who are there, I'm pretty sure we can do it as a regular annual event. But before coming everything to a close, I must thank Abhilash and his team, everybody, and all the faculties and all the delegates. And last but not the least, all the pharmaceutical companies who have given a very wide support to all of us, a very magnanimous support to all of us for running this program. I know it was run at a short notice, but I'm pretty sure we have learned our lessons. And to be very honest, with the next time when we do it, it will be done in a much better, more attractive way. So with that, I'd end my Thanksgiving session. Thanks to all of you who have taken time out on a Sunday afternoon to be present here. Thank you to Dr. Ray, Dr. Jain, Dr. Chadda, and Abhilash, and everybody who have taken the trouble of preparing your presentations. Thank you.
Before that, we need to do it more. We need to have some data. You're going to send some also.
So that Dr. Ashish was there, he's the head of clinical trials. He will need to protocol.
As a small bit, you can't do a protocol that's
No.
That's a bit high. We have to start at the low level. So you make people think it works and no side effects. So more people will use it for the right reasons, not because you're coming to my clinic and say what you want. Like 20, 30, 40, 50 and the other from your business point of view, one thing before people know, you go to the top.